Thank you for the invitation to address the Center for Community and Global Health and the Healthy Aging Challenges and Strategies Symposium. My name is Dr. Karen Krieger, and I'm with the University of Louisville School of Medicine. I'm a certified family practitioner and certified in HIV care for more than 30 years. So once a year in the United States healthcare system, our patients over 65 receive focused Medicare prevention strategies. Focusing on cancer prevention, fall prevention, advanced directives, depression, cognition, risk of sexually transmitted diseases, drug use, immunizations. I sit down with them and review their medical history, family history. I update their providers, new medications, review their blood pressure, height and weights, assess for frailty or cognition changes from the prior year, offer personalized health advice based on the risk factors that have been covered under this session. And I schedule screening tests, make sure their immunizations are up to date, and help them with their advanced care planning. But what happens on every visit during the year to my office is trying to identify to my seniors their perspective of what aging is like. For some of my patients, looking at this picture, they would see the forefront, the wide area of the street, and to be their former lives when they were head of the household, or when they were responsible for getting their children out to school every day and all the committee work. And then the narrow band leading into the distance is very constrictive for them. They're not quite sure what's going to happen. What I try to do, regardless of their disease process, is help them to flip their script from the wide dual pathway leading to a single road to the single road leading to multiple possibilities. When I thought about this topic, I was thinking of the 88-year-old AIDS patient that I have taken care of for 30 years, who had an opportunity in my office. A couple of days ago, I asked him if he was interested in a flyer to learn how to cook healthily for the Easter holidays coming up. He cooks breakfast every Saturday morning at 2 different churches in the community at 88. And he was so excited about the opportunity to go to the university to take this healthy cooking class. Our seniors that are excited about starting a new project, our seniors that are out in the community volunteering, that is the difference in healthy aging, regardless of their hypertension, regardless of their diabetes, regardless of their HIV disease. These are the individuals that are maintaining social connections with church, family, friends, and hobbies. My friends that are 10 years older than I are busy in the community, engaging, enjoying a sense of independence in their choices and well-being. They're no longer responsible for having to pay all the bills after working 50 hours a week. They now have the freedom. Sometimes it's constricted, but recognizing they have choices. Even a nursing home patient has the choice of staying in the room or going down the hall to the lunch area and meeting other people. Our job is to help them maintain their independence for as long as possible, regardless of their disease process. Every person wants to be seen, heard, and trusted. We help them to find adaptive devices for cooking their meals or cleaning their homes, for keeping up with the news, and sometimes that means closed caption or hearing aids, or having someone read to them. What makes a difference for healthy aging regardless of the disease process? I borrow this from the Apostle Paul. Brothers and sisters, I do not consider myself yet to have taken hold of it, but one thing I do, forgetting what's behind and straining toward the goal to win the prize. And so our patients that are thriving in their elderly years, they're seeing possibilities in all that they do and all that the world has to offer to be the most and the best that they can still be.
everyone, I'm Dr. Zhu Aiyong, the Dean of the School of Nursing and Health Management at the Shanghai University of Medicine and Health Sciences. I was so glad to receive the invitation to speak at the Healthy Aging Symposium and share with you something about aging here in China. First of all, I would like to talk about the current situation of China's aging issue. According to the results of the 7th National Census published by the National Bureau of Statistics, as of November 2020, there were 190 million people aged 65 and above in China mainland, accounting for 13.50% of the total population, which was higher than the world average. Aged 65 and above accounts for 9.3% of the population. In Shanghai, the proportion of population aged 60 and above is 36.1%, and the proportion of the population aged 65 and above is 25.9%. From 2010 to 2020, the proportion of the population aged 60 and above rose by 5.44 percentage points, and the population aged 65 and above rose by 4.63 percentage points. Compared to the previous decade, the aging process has accelerated significantly. It is estimated that by 2030, the size of China's disabled elderly will exceed 77 million. It is predicted that China will become a so-called super-aged society in 2033. Compared to the Western countries, China has had less than 30 years to cope with this major change. The deepening of aging, characterized by a large base, rapid growth, advanced aging, and empty nesting, poses a huge challenge to the country's economic and social development. We are a school for the cultivation of professional nursing students. So to overcome these challenges, we have made a lot of efforts to strengthen the nation's human resources. As you may know, the 46th World Skills Competition will be held in Shanghai in 2022. Health and social care is one of the world skills projects. Compared with traditional nursing that focuses on operational skills, health and social care focuses more on humanistic care and the world's relevant industry standards, which allows us to improve the competitors' comprehensive quality of caring patients, including the elderly. Our school is the training base of health and social care projects in Shanghai, and has been approved as a major training base in China. For us, it is an honor as well as a responsibility. In addition to nursing and health service and management, the School of Nursing and Health Management has also established the Healthy Community Geriatric Care Research Center, which is engaged in research on aging and geriatric care talent training, so as to better promote the health aging career. Regarding the future, the increase of government investment and industry development leads me to predict that the future will be the area of intelligent aging. We have also been promoting the data senior care service projects and the smart health apps and the facilities for senior care institutions. I believe that international exchange and mutual assistance will help us to better address the problem of aging. With the opportunity afforded by this forum, I would like to sincerely invite our friends from other countries or institutions come to China to visit us and to establish cooperation with the Shanghai University of Medicine and Health Sciences for in-depth cooperation, like in health education, chronic disease management, and family care. Let us jointly deal with the world crisis of aging. Thank you.
Good morning. Welcome. We are about to get started. Welcome to the Center for Community and Global Health's third annual symposium on healthy aging challenges and strategies. I would like to thank everyone who contributed to the smooth running of today and the many details that it took to make this happen, and especially to our guest speakers, Director Munn, as well as Bonnie Silverman, for sharing her excellent knowledge. For those of you joining us in person online, we hope you are able to gain many ideas to facilitate your ability to help those that you come alongside and help them as they're in their process of aging. I am Dr. Hannah Benge, Assistant Professor in the Division of Health Sciences and coordinator of this symposium. And now here's the Dean of the School of Health Professions, Dr. Jessica Miner.
Good morning, everybody. Excuse me. Let me go here. It's good to see you today. I'm so thankful that all of you are here. So welcome to the third symposium. This is our hope to continue for many years to come. And just to give you introduction, so just about 2 weeks ago, really, we officially launched publicly the Center for Community and Global Health in the same room. So we have a lot of projects that we are working on. You'll hear from Dr. Hicks and Dr. Kadio today. Dr. Kadio is the director of the center, and Dr. Hicks is the assistant director. So thank you so much for coming today. We hope that you will learn a lot, and please let us know if there is anything that we can help you with. Thank you so much for those of you who are online, joining us from even different countries, different states. So let us know if we can help you with anything, and we hope that you really are able to learn a lot and that we can help join in the partnership with you. Thank you.
Thank you again, Dr. Benge and Dr. Manner. I'm Dr. Bernard Kadio. I'm the director of the Center for Community and Global Health here at Bob Jones University. And the center is, the way we call it is our research hub, whereby we bring together researchers not only from this university, but also from all over the world to come together and investigate ways, avenues, whereby we can build together a healthier society for all. And the center is also what we call a bridge between the academic world, the research world, and the community at large. So it's kind of our bridge between University Street and Main Street. And to do that, we have a network of partners, local partners, national partners, and the international partners. And at this point, I would like to welcome all our global partners. We have today joining us online, the School of Medicine and Health Sciences from China, from Shanghai, China. And I was in China in 2012. It has been a while, but I can still practice my Chinese. Huan Ying Tong Xi. It means welcome, colleagues, I hope. So we also welcome the Population Health Department from the University of Cape Coast. They're in West Africa and Ghana. Welcome, colleagues. We also have with us today, joining online, the researchers from the Life Research Institute from the University of Ottawa, Canada. Welcome, bienvenue. And from here, from the US, we have some researchers joining us from the Louisville School of Medicine in Kentucky. Welcome. We also have some partners joining us from the French-speaking world. From France, we have le Réseau français pour les maladies chroniques. Chers collègues, nous vous souhaitons la bienvenue. We have also joining us from the Ivory Coast, another country in West Africa, from the School of Medicine and the National Institute of Public Health. Bienvenue, collègues, et merci d'être avec nous en ce jour. This year, our symposium has been dedicated to healthy aging, and we can all discuss about different issues and not agree, but we all come to a common ground when it comes to aging, because this is our common present and our common future. So we are kind of thrilled to discuss this because it shows the interest that we have for building, as I said before, a healthier society. And we have here some, we are going to look at it from what we call an ecosystemic way. And this is kind of looking at an issue from different angles. We have here policymakers, and we are thrilled to do that. We have also here frontline workers, that's great. We have researchers, we have some students. So we all are going to get together and look at the issue from different angles. And those are the different ingredients that are needed to create change. And this is what the center is all about. So my hope as a director is that at the end of this day, we all get enriched and we all get engaged in building a healthier society for all of us. But, you know, we cannot speak about healthy aging without hearing from seniors. So we have today the Johnson, Mrs. Johnson, and Mr. Johnson. Please join me on the podium and have a seat here. And we wanted to hear from them. In public health, our rule is that don't solve my problems without including me. That's our rule in public health. So we wanted to hear from seniors. And a very, very good friend of ours, Mrs. and Mr. Johnson have 4 children and 10 grandchildren. And I met one yesterday, actually. She was going to the orthodontist and she was excited about it. And yeah, and they have been part of our wellness program here at Bob Jones University. And I thank you for joining us, and we just have a few questions. We really would like to hear your voice and your ideas. Hello. Yes, absolutely. That will make it. And my first question at this point is what could you share with us about this season in your lives?
Thank you for having us today. I'm not on the speaking circuit, so please forgive me in my way I say things. But I first wanted to say that in fundamentals that will help us, all of us, to start with is when I was a young boy, I accepted the Lord as my Savior. That was the biggest, greatest decision that I had ever made. It was a wonderful decision. Next, I found my wife. What a wonderful, wonderful lady she is. I love her dearly. And to watch her tote over our grandchildren is very, very special. We have a wedding coming up, And I watched her make 4 dresses for the little grandkids. That was very special. She's a good seamstress. But it's hard to believe that it's been 50 years since I've passed. I was in college 50 years ago, and I was just full of energy. I played sports. I played soccer, basketball, softball, all the sports, but even played ping pong for Chinese people. Then came the time of having a growing family, still a time of constant activity. You're a parent, you know, how these little kids just take your energy away. But I have to say that of all the moms that are out there, I have the highest esteem for you moms and what you go through. It's not easy, I understand. Now we are retired from our 8-to-5 jobs that we did for about 50 years. And I'll tell you, I was sitting at my desk one day and I was just thinking about, oh, if I could only be retired. I wouldn't have to be here 8 to 5 every day. And so it happened. And now I look back and I think, I wish I had 8 to 5. I love the routine of 8 to 5. I really did. I didn't think I did when I was doing it, but now I struggle a little bit on the 8 to 5 thought. Physically, we are older and slower. However, we see the importance of trying to stay healthy. Movement, mobility is very important. Stay flexible and active. For years, the doctors tell us to walk, get exercise, keep a healthy heart. So maybe 15 years ago, being I am a type 2 diabetic, I have a wellness coach, and she helps me and keeps me in line. And it's good to be accountable to somebody, not just on your own. It's good to be accountable. Now that we are grandparents, I want to be part of my grandchildren's lives and need to work at being healthy. So I'll be there for them.
Thank you very much. Mrs. Johnson, how are you staying healthy?
Well, as he mentioned, when you're younger, I can remember back in my 20s and 30s, you just had to move. You know, there were places you had to go, there were children you had to watch. Even as a student, I can remember the miles that I walked. I don't do that anymore. I walk a mile maybe once a week, twice a week. That's really good. Whereas as a student, I was walking every day, you know, across campus to the dining common, to the gym, to the science building. You didn't think about exercise. Then as I turned 30 and 40, had kids to keep after, I was still moving. I was still, you know, getting enough exercise. Well, I will say that I kind of blame my 4 children for the extra pounds over the years too. It's their fault. Just couldn't lose it afterwards. But then I hit late 50s and 60s, and I'm a senior citizen all of a sudden. I mean, I know it didn't happen overnight, but it did. It caught up with me. I try, you know, as he said, the doctor tells you walk and do exercise. I try to do that. She did tell me one time it doesn't count to run up the stairs instead of walk up the stairs. That was not an exercise. But I found that maybe that was all I was getting. And then I had a little bit of health issue. I had some osteoarthritis, and that slowed me down for quite a bit. But as I started having grandchildren, I thought, I don't want to be that grandma that's just sitting in a chair, that's not participating. Though they do laugh at me a little bit when I get down on the floor and then have to get back up again. It's a little more difficult. But if this is the late fall or winter of my life. I'm not quite ready for it to be over yet. And I understand the importance of moving more. I had an elderly mother that we took care of for several years, and she was pretty much immobile the last 3 years of her life, but she would sit in her chair and she would lift her legs, she would lift her arms, and she would say all the time, move it or lose it. Now, some people say that to get out of your way, but you do need to move it or lose it. And I think I've learned a little bit about that. Steve and I try to be a little more active instead of just sitting around. It's important to eat healthy. With his diabetes, that's a little bit more of a challenge. We all know the things that we shouldn't be eating. You know, chocolate is not a vitamin, though some of us really like it. You have to think about your body is not going to last forever. I want to be there for my grandchildren, maybe not until the end, but I want them to remember me as somebody that was involved in their lives.
Thank you very much. And one final words, Mr. Johnson, we have here policymakers, we have here frontline workers, we have researchers, we have students, and we will be spending this day discussing healthy aging. What final words would you like to give us, please?
Getting old is not for wimps. You know that senior care is a growing concern. And it's actually a big business, isn't it, today? I have, most of my friends now are in their 70s and 80s and 90s. And it seems like it's, I don't know, 5,000 to 10,000 a month for them to even stay in an assisted living. So it is a big business, but keeping your body and mind healthy and active is a challenge. I'm older now, and I do feel some limitations. I appreciate those of you that will pursue ways to help elderly have better care and opportunities. Thank you very much.
Thank you very much. Thank you very much. Thank you. Good job. Good job. Good job. At this point, we are very, very privileged to have with us Director Connie Moon. And Director Moon has led South Carolina's Department on Aging since January 2020. And Mrs. Moon interacts regularly with agencies and stakeholders to seek partnerships and develop solutions to meet the needs of South Carolina's rapidly growing senior population. And I have a personal testimony that I would like to give. When we were putting together this symposium, we sent an email to Director Moon, and we said, will you be willing to come and talk to us about what you are doing, about the state of aging in South Carolina? Immediately, she said, yes, I will be there. And she is here this morning. Thank you very much, Director Connie. And s'il vous plaît.
All right, I need to bring this on down just a little bit. Can you hear me all right? Okay, perfect. Thank you. Well, good morning, everyone. It's a pleasure to be here this morning with you. I love driving in. It's a beautiful campus, and I look forward to my tour afterwards. It's truly an honor, and I was so excited to be asked to be here at the 3rd Annual Symposium for Healthy Aging Challenges and Strategies. These certainly are buzzwords today in the professional arena, are they not? We hear them all the time. And so it's important for us to be here today, not only community, but globally. So now we're faced with how we can have our older adults facing the challenges and keeping them living healthy lifestyles. But I am confident that after today and hearing all the panelists here this morning and listening to the Jensens this morning, sharing what it means to them as older adults to have services, that we're going to come up with collaborative ways to work together to be able to ensure that our senior population has all the services they need to live healthy, but also live their lives with dignity and respect, which they all deserve. So I'm Connie Munn, and I'm the director of the Department on Aging. Here we go. I want to share a little bit about what our mission is. And just first start off with, basically, we receive funding from the federal government as well as state government. And so our core mission is to ensure that our older adults are able to live with services in place. Some of the services that are targeted to older adults with the greatest economic and social needs, that's low income, minority, the rural dwelling. But I also want to focus on what our vision is. And our vision is to ensure that seniors and vulnerable adults enjoy an enhanced quality of life, that they're able to contribute to their communities, they have economic security, and they are able to receive the supports necessary. We know how important it is today to have that economic security. You can have all of the services available, but if you can't get to them and if you can't afford them, it's not going to help the seniors. In order to support our older adults through their golden years, the Aging Network aims to meet people where they are. Exactly what we heard already this morning is we might think we know what is best for our seniors, but we've got to ask them, because we need to make sure that we're developing the services that are available and that they want and need, not just what we think at the professional level. Listen to their stories to fully understand their concerns and their challenges. Recognize the importance of autonomy and self-determination. Older adults have the right to make their own decisions and not be influenced what others have to say. And then produce solutions that address the social and behavior determinants of well-being. I love this picture. So what is the current status of aging? The Department on Aging, we are tasked, like I mentioned earlier, to come up with a plan. And in 2018, because of the demographics that we're facing in South Carolina, the governor and the legislators decided that the Department on Aging used to be the Lieutenant Governor's Office on Aging. And so they decided that it needed to be its own cabinet level agency and shifted that in 2019. And then in 2020 is when I was confirmed as the first director of the Department on Aging. And the reason for that, and just being here 2 years, I can understand completely, because by elevating this to a cabinet agency, I have the resources to work with other cabinet agencies, with DHEC, with DSS, with our public health, all of us coming together to work around the table many times to determine what we need to do, because we know that one agency can't do it alone, but also know that as the Department on Aging, we're tasked for ensuring that our older populations are receiving the services they need. And 7 weeks in to my position, COVID hit. And we thought, this would be a few weeks, and it's been 2 years and we're still here. So I can tell you, from a cabinet agency, being able to work together and collaborate every day with the other state agencies has been the only thing that's ensured that we were able to continue serving our seniors. And they didn't miss a day of services. We were able to quickly shift with our strong aging network. So here's just a few demographics to show you as we are looking at the daunting task ahead of us. It is amazing to look and understand that according to the National Council on Aging, on average, a 65-year-old can expect to live another 19 years. Our older population is growing rapidly, and we're approaching a demographic turning point in our nation due to the aging baby boomer generation from 1946 to 1964. So by the year 2030, all baby boomers will be older than 65, which means 1 in every 5 are at the retirement age, like the Jensens here. Just 4 years later, in 2034, older adults will outnumber children for the first time in our nation's history. I think this is an astounding number. And I think as we're sitting around the table today and listening, keeping this in mind, when we used to hear 2030, we thought, oh, that's a long way away. Well, it's almost here. We're on it. And so we need to be planning for that. It's projected that by 2060, the number of individuals who are 65 years or older will reach 94.7 million. That's 1 in every 4. And this affects not only the services, but when we stop and think of our older adults that we have now, those who have grandchildren, you may have, you have children, 3 or 4 or 5 children. Now the population, they are not having as many children as they had before, maybe 1, 2, some don't have any. And that certainly affects as far as caregiving for the older population and who's going to care for them in their later years. It's kind of hard to tell from this, but I believe we can probably get this PowerPoint to anyone that might want it just to have the demographics. But this is showing the trends in the overall population in South Carolina over the past 10 years. South Carolina's population increase is 10.7% as compared to the national average of 7.4%. The South was the fastest growing region in the Midwest. Some of the trends can be attributed to retirement. People are moving here into South Carolina. They'd like to retire here. And I can understand because South Carolina is the place to be. You've got the beach, you've got the mountains, you've got, everything is here in South Carolina. Why would you want to go anywhere else? It's a wonderful place. It also has, opportunities for jobs for the younger people. So younger people are coming here and they're staying here. Just to show you the most dense population, I wanted to point that out because Greenville, right where we are, you have 668.7 people per square mile in Greenville. The most dense counties are Greenville, Spartanburg, Pickens, and Anderson, all in the upstate. We have the North Central region, which is York and Lancaster, and then Central Midlands, which is in Columbia area, Richland and Lexington, and Low Country, which is Beaufort, Charleston, Berkeley, Dorchester, and Horry, which is our coastal area. This map again just shows the growth across the nation and looking at, the darker colored mapping is where the retirees are. And you can see South Carolina way over there, but it's dark like the others over across in California in that area. I think it's important to note that no area in South Carolina saw a percentage in decline in the 65 and plus population. Unlike some of the green states in Texas, we're seeing a decline, but not South Carolina. We're seeing that increase. So in 1988, 474,073 people over the age of 65 were living in South Carolina, making the state the 25th in persons over 65. Fast forward 2010, 631,784 people over 65, coming down to 23rd. Then we're projecting by the year 2030, South Carolina will be the home to 1.1 million adults over the age of 65. Bringing us ranking 15th. Again, we're preparing for that 2030 time. It's coming. And so we're excited about that, but to have a strong network in place to be able to prepare for this population. Again, just showing some more demographics with South Carolina. I think it's important to point out here the health disparities. We talk about health disparities a lot. And some of the, and in South Carolina, we know that we have the dense areas, but we also are a very rural state as well. And so we have to take that into account because our rural areas, we found particularly during COVID, it's difficult to reach our seniors and it's difficult for them to get transportation out. So some of the health disparities for the rural population or demographic characteristics, residents of the rural areas tend to be older with lower incomes and less education than their urban counterparts. And these factors are linked also to poorer health. And we've already heard today how health is so important. Health behaviors are limited access to healthy foods and fewer opportunities to be physically active compared to the urban counterparts. Leads to obesity as well as high blood pressure. And then higher rates of smoking increases risk of chronic disease. Healthcare access. Fewer healthcare workers, specialists like cancer doctors, critical care units, emergency facilities, and transportation options, all are higher rates of the uninsured. And then healthy food access. Nationally and local studies have shown that those living in low income, minority and rural neighborhoods have often less supermarkets and healthy foods. And we know that as well. We must be able to have the healthy foods for our seniors. All of us, but particularly seniors. Again, just showing some slides of the disparities I wanted to point out. According to our recent studies, when we're comparing our older Black individuals to the white population, 27% are at higher risk of heart disease and death rates, 16.1% higher rates of hypertension, 9.1% higher rates of diabetes, 61% are more likely to die from stroke, 64% are more likely to have Alzheimer's and dementia, and 5.2% are more likely to have a decline. In the past 12 months have mentioned that they needed to get to a doctor, but they could not afford the cost to get to a physician. The World Health Organization describes how globalization, technology developments, urbanization, migration, and changing gender norms are influencing the lives of our older adults in direct and indirect ways. Some examples of that is technology for social connectiveness, rideshare options for transportation, and choice for homemaking services and meals, meaning consumer choice. We allow our seniors to be able to choose what type of meal they want. There is no typical older adult. The age group includes 5 decades of individuals with differences among the older adults are great. They are diverse in values, desires, needs, and therefore programs and resources must be person-centered. We must meet the people where they are to provide support for where they want to be. So how do we get there? How do we accomplish this? Well, we start by what you're doing here. And I love the fact that you're doing the Global Community Symposium. I'm excited to be a part of this and then also come back in the next years to hear what you're doing and hear how it's going. So here we have regional, community, individual, stakeholders, and partnerships. That's how we have to be able to do this in South Carolina. And I need to add in the global part to that because that's also how we get there. And South Carolina, we have at the Area Agency on Aging, there are 10 across the state. And part of what the Department on Aging is responsible for is ensuring that we're able to have services across the board, whether it be urban, rural. And so at the Department on Aging, has a state unit on aging, we're tasked with identifying 10 regions to have area agencies on aging. And then we have the local area, which are you've heard many times, possibly a Meals on Wheels program, a senior center. These are our local providers, and that's how the boots on the ground, that's how we get the services out to our seniors. So at the regional and the community level, we have a community needs assessment. We're in the process of conducting that right now. Our area agency is conducting a needs assessment to find out what the seniors are asking for. We know what we think they need, but it could be something completely different in the direction we're going. We have a state plan, and you can go on our website and see what our state plan is. We are required by the Administration for Community Living, which is my federal partner, to conduct a 4-year state plan, and that is completed and up and approved. So we're excited about that. And then our regional area agencies go along with our plan and and their regions do what matches the region, but try and compare it and go along with the state plan. We also have SC Act, which is a tracking system that we utilize for tracking services and needs from our seniors. And we assess and strategize areas for improvements in resource allocation. At the individual level, we have client assessments and information and referral, which helps to provide a tailored assistance. It's an opportunity to meet with seniors, see what their true need is, and also sometimes it might be a little bit different from what we think. Our seniors that receive services that the area agencies on aging provide, and I'm going to get into that a little bit more in my presentation, but in order to even receive a service, you must have this client assessment that I will talk about in more detail a little bit later. In order to do that, because we're looking at the holistic person, we're not just looking at, and in the past, these assessments were conducted. We did a pilot in one of the regions, and a provider who was providing meals went in and assessed the client. The assessment came back that they needed a meal. The provider that was providing home care services conducted the assessment. Same assessment. Their assessment stated they needed home care. So it didn't take us long to figure out, we need an unbiased person here going and conducting this assessment because we want to see holistically what that senior truly needs. This is how the area agencies got involved, and they go in and conduct the assessments and then determine what the need is, and whether it could be something that they have within their network, or it could be another resource because they have built these resources across the region and they utilize them to provide the service. And then client-centered support. This is the way that the aging programs and services can be delivered in South Carolina. It's in state of change. We are modernizing how we provide services. If COVID taught us anything, it taught us that we have to find a new way of doing things. And we're doing that now. Each of our programs offer traditional support, but now we're kind of reaching out and branding resources and ways to meet the growing needs of our senior population. So what are we doing in South Carolina? I don't know if you can see the exact number, but it's 15,658. These are the counts of in the year in 21-22, the phone calls that we got into our office. We have a service called Information and Referral Assistance Services, and every single area agency on aging has a specialist, and we have one at our office. These are calls that came in, and these are the regions, the 10 regions that I was mentioning earlier, and we can show which region is getting what phone calls and what the need is. We dig deeper into it, and I didn't get into a lot of that detail from here, but we can go in from the state office and be able to pull of the regions and see what the calls are. Is it transportation? Is it home care? Is it, it could be yard work. So anything that the senior needs, they can go in and we can track this to see what they're asking for. There's one specialist in every area agency on aging, an information referral and assistance specialist. And I'm proud to say that they have to go through a training. So it's not, we have individuals who are trained and certified. And according to our policy, if you're not trained and certified within a certain amount of time, then you're no longer able to be the IRNA specialist. And I know we talk in acronyms, I know we all do, so I'll try to remember to say the words out, but information referral and assistance specialist. So, and like I said earlier, this is what the IRNA specialists work along with the assessors to ensure that when an assessor goes out into the field and talks with a senior, and if they come back and it's not a service that program, that area agency has, then they reach out to the community. And it could be churches. Many times churches are able to step up and help us. I think I'm gonna keep it right there for just a moment and go over the next. Transportation. Transportation is a priority service for our older Americans. Its services are intended to facilitate access to services for older adults to remain active and independent in the community. It allows them to participate in social service programs, going to the senior centers, community businesses, and health resources for medical transportation. And it helps reduce social isolation. It also helps them to maintain their health and independence, and it prevents premature institutionalization. If our seniors are not able to get to the services they need, it certainly does enhance their need for institutionalization at a later time. A couple of innovative programs that some area agencies on aging are conducting is providing assisted transportation to seniors. So we know it's a lot of times our seniors have difficulty getting into a vehicle. And so they're allowed, and we have rules and regulations for everything. So there are certain types of transportation that we can provide, and we allow a pilot project so that this individual can have an escort to go with them to help them into the vehicle and help them out. Because if we get to the curb and they can't get in the car, then it doesn't do any good. Again, meeting our seniors where they need to be to get them to the services that they need. According to the U.S. Aging 2020 AAA National Survey Report, transportation is the most commonly provided service nationally. So out of 489 area agencies were surveyed, 89% came back with transportation being the #1 need. So we need to keep that on the forefront of our planning as well. Home care services. That's a program that we offer for seniors to overcome barriers to maintain and strengthen and safeguard independent functioning in their home. There are 4 services under home care that we offer. Personal care is assistance. With personal assistance, they may need help standing up, help with their activities of daily living. We have personal care. Chore is performance of heavy lifting tasks. Homemaker is just what it is doing light housekeeping or whatever it might be that the person needs to be able to remain independent. And then minor home modification, which is limited assistance with home improvements. It could be going in and changing a guardrail or putting up something in the restroom to help them. These are what we call minor home modifications. These are the 4 different types of programs that we are able and allow through our home care program. Right now, 6 of the 10 area agencies are providing consumer choice for this program. In the past, the home care program was contracted out. And so whatever contractor in that region had the contract for home care services, that's who the senior had to have in their home. Now we're going more to the consumer choice, where the senior can choose which home care agency they want to come in and provide their service. And, I think that's what we need to keep in mind, because again, respecting the dignity and respect of older adults, they need to be able to choose who's coming into their home and not have us tell them who's going to come in. So we're excited about that. It's taken us some time to get there, and we're headed in the right direction, but we're hoping in the next year or two, at least all 10 area agencies are going to have a consumer choice program with our home care. So this gives you a little bit of what the, and this might be where my slide went out. Okay, I think I'm back on track. Now, we had changed up our slides, but we're on track. This shows you what the 2018 statewide needs assessment said. Every 5 years, area agencies are required to conduct a needs assessment. That's why I said they're currently conducting it. But I can tell you, as a former AAA director, before I moved to the state office, we did a needs assessment, and I was amazed. What I thought the need was not in my region what the seniors came back. The #1 is they can't do yard work due to physical or medical reasons. They're concerned about falling or other accidents, 27%. 27% also said they have difficulty keeping their home clean. And it's difficult to me to get to the grocery store, pharmacy, or medical appointments. 22% said that was their concern. This is I don't know if you can read the number, but it's 13,384. This is the number of assessments that were conducted last year. This is the number of the assessors that go into the field, go into the homes and ask the clients what their needs are. And I'll go into a little bit more detail on the specifics of how we conduct the assessment, but we can pull, again, information at the state level. We can pull and see which region is going in, how many assessments they're conducting on a daily, weekly basis, and keep track of that and what the needs are. Now, when you conduct a needs assessment, we all know one thing that we realize and we understand is that there's never going to be enough funding to provide all the services that are needed. So collaboration and coordination is a must. But as we're going through and conducting assessments and going in and putting the information into our system, we're able to track a waiting list of how many people are waiting for services. We have HDM as home delivered meals, that's at 36%, personal care, homemaker, chore, minor home repair, transportation at 47%, congregate meals at 66%. And these are where the seniors go into the senior centers to receive a meal and some education and evidence-based programs. But it's important for us to track this type of information because as policymakers and talk with our legislators, having this data to go in and say, you know, we have 66%, we have 36% on a wait list to get a home delivered meal. We need additional funding to be able to provide these services. So this gives us the ammunition we need to be able to show the legislators, not only that, but it shows what we're doing as well. You know, we like to ask for money, but we also like to show what we've done. So, and thanking them for the money that they've given us. So we always, you know, having this is very helpful to say, this is what we've been able to do with the money you've given us. And this is how much more we can do if you give us a little bit more. So this is a wonderful tracking tool for us. We recently issued a new client assessment form with the purpose of meeting new federal reporting requirements. And we all know we always have new reporting requirements that we have to meet. To incorporate the validated tools, the new assessments look into several factors. One is the loneliness scale, the malnutrition screening tool, the expanded food security screener, and also the fall risk questions. These are all questions that we've added into our assessment tool, and we're able to track each one of them to see who is at a risk for falling, who is not close to a grocery store, who needs help with that. So the assessment is a very intense, in-depth client assessment that we do conduct. One of the programs that we provide are the nutrition programs. We have the home delivered meals and the congregate meals. The purpose for this is to reduce hunger, social insecurity, and malnutrition, promote socialization among our older adults, and it promotes health and well-being of older adults by assisting them gain access to nutrition and other disease prevention and health promotion services that are offered. We also identify nutrition and social supports through the iRNA support system and the client assessment tool. When you go into a senior center, you don't just, and I love this picture, in our senior centers, you get a nutritious meal, but also you have the social activities and physical activities. I'm going to discuss in just a little bit is our evidence-based programs. These are provided in our senior centers, and we think these are all very core. We know when our seniors come to the senior centers, it's not just about the meal. We know that it's for the socialization. It's a lot of times that interaction is all they see that day. Just as our home delivered meals, many times the volunteer or the staff person, the individual taking the meal to our senior in the home, that is the only person they see for the day or the week, many times for the ones who get meals on a weekly basis. So this picture is actually a pilot program that was started. And so when we talked about innovation and looking at new ways to do things, this was during COVID hit, we realized that we had to start doing things a little bit differently in the very beginning, because we have some very strict guidelines from the federal government on how we can provide our services. And so a lot of that is around the meal program. And what we did was partnered with restaurants, because and it's probably hard to remember back 2 years, but back in the beginning, several restaurants, when the world shut down, many restaurants had food supplies on hand that they were going to lose. So we were able to work partnerships with the restaurants, and the seniors still received the meals, and the restaurants didn't lose their food costs. So it was a great partnership. Out of that grew this pilot program. This is at one of the Lizards Thicket in Columbia, in Richland County. Senior Resources, which is a local aging provider, worked with the Central Midlands Area Agency on Aging to introduce a pop-up group dining site at the local restaurant Lizard's Thicket. So the seniors were able to go. I mean, they were waited on, they had their menu, and they picked what they wanted to eat. And our dietitian worked with them to ensure that it was healthy, because I mean, I know I'm probably, it's a commercial for Lizard's Thicket, but who doesn't love their fried chicken and biscuits and everything? So we know that we had to keep it a little healthy, and we did for our nutritionists work with them, but it was still very delicious. And we were all there to kick it off. It was an exciting time, and our seniors loved going. Not only that, but just hearing their stories, because at the very first one, they went around and every senior there was able to share why they were there and what it meant to them. And some had lost a loved one and their spouse, or they had been there with their spouse, and then they were having to come without their spouse. So it was a wonderful opportunity for our seniors. So we're again hoping to expand this more, even up here in the Greenville area. I'm happy to come up here anytime and work with y'all to get something going. What we realized that our adults really love the choice. And I think that's what we keep coming back to. It's just the consumer choice and our seniors being able to choose what they want to do. We are in the process, as I said, of releasing an Area Agency on Aging restaurant partnership guide. Again, when we look at pilots and different ways to do things, it's important that we don't just stop there. We continue it, whether it's a guide, a toolkit, whatever it is, so that any of you here can say, you know what, Connie, I really like what you said. How can we do it? Well, here it is. We have a guide, to be able to track it. And again, tracking the data to show what's working and what isn't. Because if we need to back up and fix it, we will. But it's so important to also have guides so that you can do this project in your area. COVID-19 and the closure of senior centers opened up really new opportunities for social connectiveness. And so some of our area agencies and local providers converted to a virtual platform to connect seniors to nutrition education sessions. And we know that was very difficult to do. I think it's also helped us to understand as well in the very beginning when we thought there's no way our seniors cannot do this. They can't use their phone. They don't know how to use an iPad. Well, they can, and they did, and they surprised us all. So this is exciting to know and to help us moving forward what we want to do, because while they were shut down and isolated, they were able to still join in. An example that we use is, and I'll talk about this a little bit later on, is our family caregiver support program. We know when the world shut down, our caregivers were at home with their loved one 24/7 with no support. But allowing the virtual platform, they were able to participate still in support groups and get the support they needed during the process. Of course, we all know that many areas in South Carolina do not have broadband. So we know that's an issue. Again, a policy issue that our state needs to address, and they are, but it's a huge issue for how we're going to get services out there, because and the telehealth aspect of it as well. So again, just a few more statistics for you. Talking about the food insecurity, it is the greatest amongst the racial and ethnic minorities, those with lower incomes, and those who are younger in 60 to 69 age group and are renters. Income-related data, for those incomes below the poverty level, 32.1% have food insecurity. For those with greater than twice the poverty, 2.6% have food insecurity. Seniors, Caucasian seniors have food in rates of 5.9%, which is less than half the rate for our African Americans, who are at 15.2%. In South Carolina, 8.5% of seniors have food insecurity, and the national average is 7.1%. So we have some work to do in South Carolina to address the food insecurity issues for our older adults. Malnutrition, 1 out of 2 adults are either at risk of becoming malnourished or they are already malnourished. Disease associated malnutrition in older adults is estimated to cost $51.3 billion annually. That's astounding. We have to do something. Those that are at greater risk of malnutrition are older women, minorities, and people who live in the rural areas. And so we have to make sure that we have a system in place that they get the food that they need. One of the pilots that we also did that we were able to provide during COVID, again, coming out of COVID, we had a lot of flexibilities that we were able to provide. We have guidelines and rules, regulations, I know, but we had food boxes, and that was important for many of our rural population, because as we're out in the field, as we're conducting assessments, if we look in the pantry and our senior does not have any food in their pantries, then we have a food box we can give them. And we cannot pay for that out of our federal dollars. I think that's important. That's what we're working on right now with our federal government, is how can we relax some of the flexibility so that they're not so stringent on these services that we're providing. We saw a big difference in what a food box could do for a senior to allow them to have food for at least 2 or 3 weeks until the meal that they were qualified for started coming into their home. This slide that I'm looking at, that you're looking at right here, is on the senior outreach and partnership building. This is important because we're talking about social isolation among our seniors and influencing that among older adults: race, ethnicity, immigration status, sexual orientation, gender identity. All of these affect social isolation among our seniors. Older adults are at greater risk of experiencing social isolation, includes those who are divorced, widowed, or separated, and older adults who were never married. Those who live alone. Living alone is a well-documented risk factor for isolation, although not all who live alone are isolated. And those with a disability and older adults who are homebound. A condition that limits daily activities can restrict social functioning. Physical impairments that limit monthly mobility can bring about social integration barriers, resulting in fewer social contacts and greater feelings of loneliness. And those living in poverty, economic constraints can present social activity barriers and a risk for poor social interaction. And this slide just shows, it's in South Carolina, the percentages. For thousands of South Carolinians, the state of aging is a solitary, isolating experience, especially in the rural areas. Last year, the Department on Aging and Palmetto Care Connections joined in the creation of a pilot project to use technology with our seniors who were at risk in 5 rural counties. So what we did was provided iPads to these seniors, 1 year free of internet service and digital literacy trainers. This was a phenomenal pilot project. And so what we saw were our seniors learned how to use an iPad. They were able to connect with their loved ones. Most importantly, they were also able to connect with their physicians, the telehealth aspect of it. We had a situation, and I believe ETV is following the story, with an individual who needed to go to a cardiologist and they couldn't get there. And so by telehealth, they were able to do the Zoom meetings and get to MUSC and were able to receive the care they need and are completely healed. And so that is an amazing story. So we want to continue to share those wins, because that was a huge plus. They also were able to get on Facebook and Zoom with their family members. So we've expanded that, and I wanted to just reach out to Spectrum and of course Palmetto Care Connections. These were all partners that we normally have never partnered with before, but it's again something that we're looking to expand and go into the other rural areas. To better meet the needs of our rural seniors and where they are, we're also working to improve the digital literacy rates. We're working with our local community partners to ensure that all the training materials are culturally appropriate for each individual where the program operates. Again, meeting our seniors where they are. What we might need up here in Greenville in the upstate is not what in my rural area of Lee County, where I grew up, needs. So making sure that each one of the programs meets the seniors where they are. Just a few more stats for you. 1 in 4 seniors in the U.S. live alone. The Southeast has a high concentration of states with seniors at risk for social isolation, according to the 2018 senior report. And senior isolation is associated with 29% increased mortality, 59% increased risk of functional decline of activities of daily living, and 20% increased mobility. 24% of community dwelling seniors or 65 and older are considered socially isolated. And 22 million seniors have no internet. 2 in every 5 seniors have no internet. Only 73% use internet. And we're looking to improve that with our partnerships that we have. This map shows the evidence-based programs that are across the state. There are 13 evidence-based programs that we provide, and we know the importance of evidence-based programs that keeps our seniors active, healthy, walking. We accomplish this by a client assessment is that my time? Okay, I've already keep me in check. Can y'all tell I have a habit of going over my time? They have timers on me, so I'm just making sure. But evidence-based programs are so important because it keeps our seniors active. And this map helps you kind of see what is offered in your county and in your region. We have trained certified instructors who provide evidence-based programs, and they're offered at multipurpose senior centers, meal sites, recreation centers, churches. They incorporate physical activity, nutrition education, chronic disease management, or mental health. Activities that are implemented promote healthy behaviors. Programming is also provided in collaboration with other state agencies and university systems. We have one of the area agencies down in the Trident area who works with Roper Hospital to provide an evidence-based program. So the seniors are at Roper and they provide that there, which is an incredible program. Some of the ones that we offer are the Tai Chi, the Fit and Strong, a Matter of Balance, and bingo size. We do know in our senior centers, bingo is still the game of choice. I would tell you, if you ever go to a senior center and you get in between the bingo and the prize and trying to present nutrition education, you'll have to wait. But so there's a evidence-based program called Bingo Size. So these are several programs that are offered in South Carolina. Again, the Powerful Tools for Caregiver is a program as well that now is evidence-based. And we realize that is a caregiver program for our caregivers to teach them, as they say, their toolkit on how to care for their loved one. And that is now, we can pay for that with our federal funds because it's considered an evidence-based program. And this is just a picture of someone who is participating in the Tai Chi evidence-based program. A couple of partnerships to highlight that we have done in the last few years is with Clemson University. And we worked with Clemson and the Institute of Engaged Aging. We serve on a steering committee with them to assist seeking out master trainers for implementing the Matter of Balance in the rural counties. And we're working in the Appalachian region up here, as well as the Upper Savannah and Central Midlands region. We also have worked on occasion with DHEC to provide SNAP Ed education. And we're partnering with Clemson Extension to provide hypertension management programs. COVID-19 and the closure of senior centers opened up new opportunities and alternate ways to provide evidence-based. Like I mentioned earlier, the virtual evidence-based for like Eat Smart, Move More, Weigh Less, and then partnerships with the University of South Carolina with assistive technology. We have an iPad and a management program to loan out iPads to our seniors. Equipment includes Wi-Fi and cellular data. And so this is a very important program partnership that we hope to continue over the years. I'm very excited to share this with you. This is the Older Americans Home Modification Project. We just got this grant this past year, and this is a new project. The Department on Aging has never worked with HUD before, so we were excited to get this $1 million grant. And again, part of it is we know the cost of institutionalization. And so by being able to go in, we've hired an occupational therapist and she works with all of the area agencies on aging. We felt like we have the infrastructure in place already, which is why it was a perfect marriage for us to do this with our area agencies, because they're already in the homes. We already know the needs and what the seniors need for their home to possibly, it could be lighting in a hallway, it could be removing certain barriers, anything that the occupational therapist sees. We have allocated $5,000 per home to be able to go in. You had to be because of HUD, you had to be low income, over 62, and reside in a rural county. So there are 29 counties that we are working in, and this is the map shows those counties. The gray areas are the ones who we're not able to work in. But again, our goal is to show our state legislator with this funding that we are able to do this at much less cost than someone having to go into an institution because they've fallen and now they're not able to go back home again. So again, I think it's a win-win for us. We're excited about this, more to come in the next 3 years as we build this program, but this will keep our seniors at home for longer and living active. Chronic disease in South Carolina, we know, is an issue. Residents residing in the rural areas are certainly more likely than those in urban areas to die prematurely from the 5 leading causes of death or heart disease, cancer, unintentional injury, chronic lower respiratory disease, and a stroke. Multiple chronic diseases account for 2/3 of all health costs and 93% of Medicare spending. Less than 1% of U.S. healthcare dollars is spent on prevention to improve the overall health. So we need to take away this. This is what we need to be focusing on. Minorities in chronic disease. Again, this is discussed this a little bit earlier, but just pointing out the need to ensure that we are addressing these chronic diseases and we're ensuring that we are getting the education out to our older adults, to our rural minorities, so that they are able to receive the services that they need. Another acronym, this stands for Alzheimer's Disease Resource Division. This map is of South Carolina. We have, last July, we were able to establish within our Department on Aging a new division called the Caregiver and Alzheimer's Resource Division. And the reason we did this is because we realized that the dementia and Alzheimer's population for our caregivers is growing substantially in South Carolina, nationally and globally as well. So what do we need to do to fix that? The legislators actually put in their budget and gave us a position last year for a dementia coordinator. So when we received that funding for the position, we thought we need to have our own division and let them be able to do what needs to be done for our caregivers. The assessment tool for the family caregivers, we do assessments on everyone. For caregivers, has been updated to better assess the needs of the individual in order to better utilize service areas for our family caregiver. We have respite counseling, training, information and referral, support groups, and supplemental services. Every caregiver is assessed to determine what it is that they need. Leading the advocacy and finding out more is written in black and white on a piece of paper. You need to be face-to-face with our caregivers, talking to them, and being able to see them face-to-face is so important. The Alzheimer's Resource Coordinated Center Council is now fully funded. This is a council that has a 29-member council, and it represents everyone across the state. It's appointed by the governor, and there are subcommittees that meet. This first time, this has been in legislation for many, many years, and this is the first time that it's ever been fully appointed with the 29 members. The 4 areas are research and evaluation, professional care, in-home and facilities, public health, early detection, diagnosis, and brain health, and community programs and caregiver support. Having a fully funded staff person at our office since October has allowed us to broaden this program and reach and provide services and supports to diverse and underserved communities. The Department on Aging works with the South Carolina Respite Coalition. We provide respite care and support and awareness through their Lifespan Grant. And we also have initiated a partnership with Women's Missionary Society to provide caregiver training and respite care to the rural minority population affected by Alzheimer's and related dementia. This again is a wonderful pilot project that we have worked on. And at the end of the program, we'll be able to give you some statistics on how many caregivers they were able to reach and help. The powerful tools for caregiver training that I mentioned earlier, this is what these women and the churches are offering our caregivers. And we know reaching out to our churches, the faith-based communities are key. And we can't forget them as our stakeholders, because many, many times our seniors, that is who they trust the most, or their faith-based leaders. And so being able to reach out, we've had some pilot projects where we have break rooms, and we were able to provide assistance for the churches to have a break room where the caregiver could bring their loved one with Alzheimer's, and they had someone trained to be able to sit in the room with them while they attended church service. So out of that, we started thinking, well, that's fine on Sundays, but many times we know our seniors and our older adults, particularly our women who were used to going to their Bible studies all during the week, and that was where they got their strength. We're not able to do that anymore. So let's open up the break rooms for more than Sunday, but during the week as well. There are many things, and I won't get into all the details, but there are a lot of things to consider when you have a break room, down to what helps that person with dementia feel most comfortable, even down to the color on the wall. So it's soothing and it doesn't cause them to be distressed. The lighting, several things to take into account. So we have a toolkit for you on that if anyone is interested, to be able to help you go back to your community. Again, if you have your church that's willing, it's at very low cost, so you could have your own break room. So this is where my team needs to say, because I got to write this down. Okay, so let me just. This is some statistics on our labor force, okay? We know when we looked at the number of the population, and in South Carolina, we know that seniors at the age of 55, they don't want to retire. They have a lot of good years left. And so we called it the Senior Community Service Employment Program. And this is an employment program for 55 and older. The idea is for them to be able to be employed later on. It's a project where many times it's our senior centers that are a part of this. So the seniors go in and they work. And the goal is that then after the program ends, they will hire this senior to be full-time employment. And I'm just going to highlight some of the other services that we also provide. We have a legal services program, state health insurance assistance program, which we call SHIP, vulnerable adult guardian ad litem program, and the long-term care ombudsman program. So I just wanted to kind of briefly talk about, because it's an opportunity for some, if you know of anyone. The Vulnerable Adult Guardian Ad Litem program is a volunteer program. And these volunteers are they are trained and recruited, and they represent the best interests of the vulnerable adults who have been taken into custody by the Department of Social Services. And so they work very closely. They're in the courts with them. There's always an opportunity for a volunteer, and you can go on our website and find out more information about that. And the ombudsman program, just to highlight as well, the ombudsman are the ones that go into the facilities. Even when COVID shut down, our ombudsmen were considered essential, and they go in and they advocate. Many, many times, residents do not have anyone to look after them, to advocate for them, for their rights. So our ombudsmen are in there daily and weekly checking on the residents to ensure that their rights are protected. Again, that's another volunteer opportunity, because we have the Volunteer Friendly Visitors Program. And we feel like the Friendly Visitor Program helps, because if the friendly visitor is in there during the week, then the ones coming in with the badge and the hammer, it doesn't have to happen as much when those friendly eyes are in there on a regular basis checking on these residents. And this is just to share with you a pilot project. Again, we have to, there's, I hate to say it's good, because nothing was good about COVID, but a positive that came out was a partnership with the Department of Corrections. This is called Spread the Joy. When we were on our daily calls with the governor's office and all the other cabinet agencies, they heard me constantly reporting on our residents and our family members calling us because they couldn't get in. And it was just so stressful. We didn't know what to do. We were protecting the resident, but still the family members couldn't get in. So the director of the Department of Corrections called me and said, look, our inmates would love to help. They made homemade gifts. It was called Spread the Joy. They did over 2,000 gifts, and we were able to take those gifts into the residents that couldn't see family members or see anyone during the holidays. So from that, it was such a huge success that we are doing this now on an annual basis. So we're very excited about this partnership. And, one of the quotes that one of the inmates said, which I'll never forget, was they know what it's like to be locked away from their loved ones. And so if they can make a card or a gift or anything for that resident, it makes a difference to them. And finally, here it is. A picture speaks 1,000 words, or one word, independence. I love this because the bottom line is that's why we are all here today. That is why our staff comes into work every day. It's to make a difference, to ensuring that our older adults have independence, that they have the consumer choice, that they're able to choose what they want and to do so within their own homes and their communities. So again, thank you for the opportunity to be here today. I'm looking forward to hearing everyone else's presentation, and it's truly an honor to be asked to come to this symposium. So thank you for the opportunity.
So if anyone has any questions, we'd be happy to have a microphone that will go around to capture everything.
Thank you. I read an article about a program between elderly people and children, and particularly orphans, and just the needs that it met for both of those populations. And you think with COVID, those things couldn't happen, but younger children are not as good as health hygiene, so you have those potential problems with some health things, but it really was a positive things for both of those groups to be able to share. So.
That's excellent. And, actually, we have intergenerational programs. One of the programs that happened during COVID was we had seniors, we had adults and seniors, and also the high school students who wrote letters to the seniors, and they would deliver those letters with the meals when they got the home delivered meals. But you're exactly right. It's very important it's important for our younger generation to know all that our older generation has to share. And so we have a lot of intergenerational programs within our senior centers, and ensuring that we bring those two generations together. I'd like to hear more of that program you read about as well.
Thank you. Good morning. And thank you for a wonderful presentation and all the work that you do. I have two questions. My first question is, how do you determine which counties have the evidence-based programs? We serve in the Anderson area, and I noticed that those programs aren't available in Anderson County. And also, there was one other program that I noticed was not available in Anderson County. So that's my first question. And then my second question is, what's considered low income for the Council on Aging?
Well, to answer the first question, the area agencies on aging are responsible for conducting the evidence-based programs. And I'll have to check on that. We might need to update our map because I'm not sure that Anderson doesn't. It might just be that we didn't get that on here, because I felt like most evidence-based programs were across the state in at least each county in one area. But the area agency, by conducting these assessments and determining what the need is, are the ones who determine who has evidence-based programs as well. And I think my staff has written down your second question, and I will have to get back with you on that.
Good morning. Can you give me an update or some information about the Medicaid program in South Carolina, specifically to skilled nursing placement?
Well, I can tell you that the South Carolina Department of Health and Human Services is a Medicaid agency. And so where we work with them, but we don't have, as far as the policy, we don't have a lot that we can do with that. But let me say, one thing that we have been doing is there is a long-term care task force. And what we have done, and I've been serving on that task force for about the last 9 months, is that we realize we have a lot of issues and problems with the Medicaid and the reimbursement system and employee retention problems. So we're developing a policy paper, and that is so that we're all speaking from the same paper, if you will, when we're talking to our policymakers across the street, understanding that something has to be done for that. So I can just say that I'm working on a task force with that and that there's more to come. But we are not specifically the agency that handles the Medicaid program and the reimbursement, but we're serving on committees with them to address those issues. And I'll be happy to talk with you afterwards if you have any specifics.
You spoke about churches and involvement with seniors, and I was just going to give y'all an idea. Our church youth group met with the older adults in the church to have a session on how do you work your computers and your social media and your laptops and your telephones. So I just was going to pass along that idea.
Thank you so much, Director Munn. It's so exciting to hear what's happening in the state of South Carolina, especially after those demographic information and the pilot studies sound thrilling about the possibilities for coming alongside our seniors and helping them age in a more healthy manner. We will now take a 15-minute break. There is a restroom right through these double doors to the left or straight back through these back doors, and help yourself to some more refreshments, and we'll see you in 15 minutes. We're going to start our next presentation. Hopefully I had a good break, got some stretching in, and good conversations going on across the room. So we are privileged to have another wonderful speaker. Bonnie Silberman is a licensed master level social worker and an advanced professional member of the Aging Life Care Association. She is the owner of Geriatric Resources Incorporated, which is a private aging life care practice. It provides elder care consultations to families and older adults. She currently also holds the roles of chapter president for the Southeast chapter of the Aging Life Care Organization and is a board member for the Greenville Area Parkinson Society and the Upstate Senior Network. She's also a member of the Greenville Professional Women's Forum. Bonnie has experience working with families and persons with developmental disabilities and has worked in health, aging, and wellness with an emphasis on older adults in the upstate since 1992. Please join me in welcoming Ms. Silberman.
Oh, goodness. Hello, everybody. Good morning to you. And I'm a senior. So, you know, I fit in those statistics. I am so happy to be here and so honored to be asked to be a part of this very esteemed group. I'm so impressed with what BJU is doing, and I'm very honored to be here. So thank you, Dr. Benge. Thank you, Anne Marie, wherever you are, for all of your supportive phone calls, and again, for inviting me to your third symposium. I also want to say to those of you wearing green, you're very smart. Happy St. Patrick's Day. I have green earrings on, and I have green eyes, so I'm safe. So don't be saying she's just wearing navy. Anyways, let me just see what I have next. Oh, no, not yet. Okay. So I've heard it said that aging is a human experience, not a healthcare experience. And when I asked the person who said this what their intention was behind that statement, she responded in saying that we may miss the opportunity to look at aging as a developmental stage, such as we do every other life stage. Those of you that are parents know how keenly aware we are of our children's developmental milestones. And we're always planning, aren't we? From the type of diapers we're going to use, to the bag we're going to carry them in, to the motor skills they're going to develop, to what's going to happen when they go to elementary school, middle, high school, and then off to college, and then off the payroll. And that's, now it's just visits home whenever we can. But I beg to differ. I think, and so did the person who said this, that like all life stages, if we plan, we seek advice and resources, perhaps we can be better prepared for healthy aging. And of course, as we age, health events will crop up, and those of us blessed with good health will ride the journey. But I say that we can begin to look and talk about aging as just that, part of life's journey. If we're living, we are aging. It's a true statement. We're all aging, right? So I thought I would begin by telling you a little bit more about the work that I do as an aging life care professional. So it will give you a framework of understanding of our work and its relationship to healthy aging, and hopefully drill down to the person-centered work that we do that Director Munn had told us about. I'm just so thrilled with the fact that the state has its own Department of Aging. So kudos, kudos, kudos. I love quotes, so I had to put this up. I just love what it said. Old age will only be respected if it fights for itself, maintains its rights, and asserts control over its own to its last breath. Cicero. When I look at that, especially in light of what Director Munn told us about, it takes a village to fight for one's rights, doesn't it? And to be able to assert control to our last breath. So what is the Aging Life Care Association? Let me tell you a little bit about it. For nearly 38 years, the Aging Life Care Association, which was formerly known, and this is a mouthful, as the National Association of Geriatric Care Managers, has been providing support to and services to older adults and their families. There are over 2,000 of us throughout the United States, and I believe there are some overseas. We are comprised of solo practitioners to multi-purpose agencies with backgrounds mostly in counseling, social work, nursing, physical and occupational therapy. And I should have, if I don't already, I may at the very end, aginglifecareassociation.org is our national website. We have a vision of inspiring excellence and a mission to promote and lead the community of aging life care professionals through our unique knowledge base, continuing ed and so forth. So who are we? Well, here's one. We are credentialed, we are licensed professionals, and we adhere to a strict standard of practice and ethics. And I think that's really important to say. In the work that we do, we are not affiliated with an agency necessarily that provides a particular service. So there is no bias. We are person-centered. When somebody engages our services, we are looking at you, and I'll talk a little bit more about that as we move forward. But our role is to help look at or support folks looking at what's most immediately needed to whatever decisions we make now, how are they going to impact in the long view? Again, we have a code of ethics and a standard of practice, not only with our individual degrees such as social work or nursing, but also through the association. And it's carefully monitored. And we are knowledgeable in 8 focus areas, which I put up here. This is one of our slides that we often talk about, the knowledge areas that we focus on, because we look at an individual from a holistic point of view, again, person-centered. We take into account through assessment one's strengths, challenges, and we create a plan of care that is specific to that person, their wants, their needs, their goals, addressing what, again, may be needed now, along with an eye for the long view. And our expertise is in these 8 knowledge areas. We take into consideration these things and are available for crisis intervention, health, understanding health and disability, the financial situation of the person, their housing, the family, and the dynamics that will always be present because we are human beings, right? Local resources, advocacy, and legal issues. Make sense so far? Oh, I should have started off by saying this. My daughter's not watching this, but she helped me with this PowerPoint presentation. So let it be said to the public and to the world, Danielle Silberman, thank you so much. So the value of working with an aging life care professional. There was some research that was conducted by our Florida chapter of aging life care professionals, and it studied how the care recipients and the responsible party, and the responsible party is the person who hired us, valued the services by an aging life care professional. The findings were this, that 90% of the responsible party respondents felt that engaging an aging life care manager had a positive overall effect on their loved one, be it a parent, a sibling, a friend. 99% said that engaging aging life care manager services had a positive effect on their own lives. These responsible parties, again, the ones that hired us or engaged our services, cited that what was important is that we kept them informed about their loved one's status, and that was the most common care manager function, followed by emergency management and medical management. All of these services work together to set the responsible party's mind at ease. The most common services beyond wearing a banana as a smile were assessing, monitoring, and updating the responsible party on their loved one's needs. We manage crisis, safety concerns, or conflicts in their loved one's lives, advocating and coordinating any medical concerns, providing support and services that preserve their loved one's independence, offering activities that enhance their loved one's social support and quality of life. And all of this, really complements everything that the state is doing, and providing impaired memory support and services. Overwhelmingly, the survey indicated that engaging an aging life care manager or professional had positive effects for the responsible party and their loved ones served. And the most common benefits, again, were getting an objective assessment of their loved one's needs, knowing that they had a medical advocate, boots on the ground, because a lot of the responsible parties, and I'm going to tell you more of this later in some case scenarios, are adult children or family members who live out of state and they can't be there. They need a boots on the ground person who can help them. And then again, most importantly, simply contributing to their peace of mind. So I love these photos that she chose. I love that lady in the middle. So what is successful or healthy aging? There is a book by Dr. Louise Aronson. If you haven't read it or taken a look at it, please do. It's her book called Elderhood. She speaks to the different definitions for healthy or successful aging from these different lenses. For the healthcare professional and researchers, it's the absence of disease, maintenance of physical and cognitive function, and full engagement in life. For the psychologist or the social scientist, she suggests it's got more to do with life satisfaction, social functioning, and psychological resilience. And to the people we're talking about, older adults, it means independence, spirituality, comfort, coping, meaningful relationships, and contributions to society. the body-mind experience of life, healthy aging, successful aging. I think you can all agree that at any age, an optimal life would include all of these. She also goes on to say that how we age is determined by personal choices, genetics, social situations, and the public policies that shape our day-to-day world. Bring the broadband on to the rural communities, right? So what does quality of life mean to you? For some, it's maximizing energy, simplifying demands, reducing pain and discomfort, focusing on activities that bring joy and meaning. And according to a Forbes article in 2013, it's very subjective, isn't it? It really depends on life events. It's multidimensional, physical, psychological, and so forth. Cultural perspectives are different depending on who we are and our country or of origin. Physical, social, mental well-being, and the interpretation of what is quality of life, so very personal. A level of acceptance and ability to regulate negative thoughts and emotions about experiences or conditions. That would take a conversation onto its own, isn't it? But that's all about gratitude and being positive in my definition. Quality of life is the ability to spend your days doing the things that give you joy or bring meaning to your life. Aging is about change. And of course, we've all been changing and aging from the moment we are born, physically, mentally, emotionally, and spiritually. Aging is fluid. If you line up a group of people 65 and older, you will see remarkable variation. If you have them stand in chronological order, you may be surprised that there are some in their higher years that appear to have more vigor than those in the younger years. Now, that's not for passing just judgment. It's just simply to acknowledge that we don't all age at the same rate. We are living longer, and they're all moving to South Carolina. Only 100 years ago, the average person lived to their mid-50s, and now the average life expectancy is in the late 70s. If you've made it to 70 already, there's a 20 to 30% chance you'll see your 90th birthday. I'll be 70 soon. As far as for children born today, 10% of little girls are likely to live to 100 or more. So are we living well? Are we aging healthier? Well, while we are living longer lives, many of those years are spent managing some multiple chronic conditions such as COPD, diabetes, high blood pressure, congestive heart failure, Alzheimer's, and other dementias. It is these chronic conditions that can profoundly impact our daily experience of life. So what can we control? And we've talked about this, of course, but the importance of lifestyle changes to manage these chronic conditions cannot be overemphasized. Ideally, ones, and I think the Johnsons referred to this, started to make some changes in midlife. But even in later years, eating well, stopping smoking, becoming more active can do a tremendous amount to help you feel better and to stay independent and to do the things that you enjoy. There was a woman that I worked with well into her hundreds, and this is what she told me. If you always do this and you do the same thing with your ankles, that you will live long. I do this every morning, and I think you should too. Do your ankles too, okay? She always had her pearls on. So I like this. Quality of life is the ability to spend your days doing the things that give you joy. It's a personal decision. It's person-centered. What's important to you? Well, everybody likes to study what's important, and whether you agree with this or not, Pew Research studied this notion in 2013, and the two most important from the people that they interviewed was the ability to talk and being able to dress oneself. Followed by being able to feed oneself, getting enjoyment out of life, living without severe or lasting pain, having long-term memory and good short-term memory, and feeling what one does is worthwhile. So now I want to talk with you a little bit about, give you some case illustrations, because I think stories, the people that we work with really tell the story. And what it means to these folks that I'm going to talk with you about in terms of healthy aging. So I'm going to call this first group the Flowers. It's a couple, and I call them the Flowers because they had a beautiful garden. And I'm going to tell you a little bit about how I met them. I worked with them over a course of 3 years and what transpired during that time. So this was a lovely couple in the community that had bought what they had thought at the time their forever home. It was a ranch style home. It had large hallways, cabinets were right, weren't too high for them to reach, easy access to the garden because they both love to garden. Everything was just, it was a perfect design. But I will say one thing, and I did question this when I met them for the first time. Their driveway was so steep and you had to go down that driveway to get the mail. So I didn't quite understand the architect's design in that regard. So pay attention to that. You might find your forever home, but don't get a steep driveway. But regardless, their son, they have 3 children. One of them lived out of the country, one lived out of state, and a daughter lived out of state. And I don't know about you guys, but if you have any siblings, everybody plays a role, right? Whether it's the older, the middle, the baby, everybody has their particular role in the family. And in this family, one of the sons, the older son, played that role. And he had learned about what we did for a living. And because he had been getting many calls from his parents and frequent visits coast to coast because of hospitalizations, he really wanted someone to be there, boots on the ground, to help navigate these medical crises that were happening, or hopefully maybe deter them and create some supports that would enable them to stay at home. The wife had some recent knee surgeries, which prohibited function, and she needed more help in her home for meal preparation, for light housekeeping, gardening, and some of her activities of daily living, like dressing and showering. And the husband had 1 lung, and he was very able-bodied, but as the older he got, his lung capacity decreased in the surviving lung and wasn't able to attend to some of these activities. And in their role, she was definitely the homemaker, and he was, he liked to watch Judge Judy. So that's what I remember. Anyways, they were lovely, lovely people. But as time went on, their health declined. And when we first met them, we were able to provide them with some agency support to provide help with the ADLs, with the light housekeeping, with the meal preparation. And as time went on, as their needs increased, that care turned into 24/7. And one of the things that I'm going to talk about this in just a little following the slide, but they had, they both became very ill at the same time with, remember the norovirus? I mean, there's always like a marker of some virus that's out there. Well, that was the neuro for them. And they had a 24-hour caregiver who called me and said, I just called EMS. They're just both really, really unwell. And well, let me just hold off on that. I wasn't going to say that right away, but anyways, let me go back. Their health declined. We had 24/7 help. And over the course of these 3 years, there were lots of open conversations, clear, concise, very difficult conversations with them and with family, what the children wanted, which was them to be closer to where the older son lived. And what they wanted was to stay in their community with the friends that they knew and loved. But as you all know, as we age, we lose people, and some of their best friends weren't able to be that support for them any longer. So the more conversations we had and the more, lots of, at that time, there was no Zoom, it was Skype. We would have Skype conversations with the family and the grandchildren. And for them, they decided, once they got well again, after that one incident, which I'll tell you about again in a little bit, we were able to, I collaborated with a colleague of mine in California where the son lived. She looked for assisted living communities near his home. He went to see, they did a virtual visit. We helped them with a moving company that helped them identify what furniture would be important for them to take and that would fit in their new space. We helped with the assessment in terms of their ability to safely travel. Did they need a nurse or could they do it with another family member? And we helped all the way to the very end, to the transition to their new community where they lived for the rest of their lives. For them, healthy aging, successful aging was being closer to family. That shifted for them. It was a pivot. At first it was, I want to stay home. I want to be here where my friends are, but they were seeing their friends having some similar difficulties. And they had such a strong and wonderful family support system that pivoted to wanting to be there for their grandchildren and be there for their surviving children. So this slide kind of will lead me to more of the discussion about what happened to them when they got really sick. But one of the strategies for aging well, obviously, is to assemble your support team, whether it's a formal support team or an informal support team. And you know what I mean by that: friends, neighbors, family, professionals like myself, your physicians, your medical health team, any advisors that you might have, whether it's in financial advisors or insurance advisors. But it's good to have a team of people that you can rely on. And the other thing that's really important are 5 important things, and this is really drilling down to the specific. Having a list of important details that are accessible to these people on your support team. Why? Because when the Flowers got ill, they were so sick, they could not tell us where their insurance cards were. They couldn't tell us what hospital they preferred to go to. They couldn't tell us what medications they were on. These things are so important to have, I think, at any age, to have the people that are important in your life to know what's important and where it can be accessed so that you don't get, you know, fortunately, I had that information. I had it, but we didn't have it accessible to the caregiver. Boy, did I learn quickly after that. They had a big binder available. But at the end of the day, they ended up moving, you know, to where they wanted to be with their family. Didn't she choose like awesome pictures? It just kind of, anyways, let me tell you about taking care of Sally. Some of the work that we do is guardianship, where the, and we're very intentional about which cases we take on as a guardian. And a legal guardian in the state of South Carolina is somebody who is responsible for a person's well-being, medical, and their residence where they're living, as opposed to a conservator who is responsible for managing the money. So in some cases, we are asked by the court if we would be a professional guardian. And in the state of South Carolina, you can be a family member also, but if there aren't any family members, they'll rely on calling a professional like ourselves. So this story about Sally is that, where do I begin? I have, some of you in this room know this story. I have a person in on my team that works PRN for me, but she also works for a hospice agency. And she was working with a family, with a gentleman who was actively dying. And when she became involved with with him, she realized that he was taking care of his mother, who was into her 80s and had dementia. She knew that when her son passed, there would be no one to take care of her. There was no other known family or friend, neighbor, nobody. There was no, they were sort of lived in a little bubble all by themselves at home. And so while he was still at home and still in this world, my staff member was able to coordinate with a non-medical home care agency to come into the home to begin providing some of the care that he was providing to his mom, develop a relationship with her, keep her safe, fed, clothed, and so forth. My colleague called me and said, we have this situation. I'm going to talk to an elder law attorney. Will you consider taking this woman as a guardian? And we didn't know anything about her. We didn't know if there was money involved. It didn't matter. The heart is that she was going to be by herself. So this non-medical home care agency went in and began establishing rapport with her, providing her the care that she needed. The elder law attorney worked with the probate court, petitioned for guardianship. We talked with an executive director of an assisted living in town, where we moved her to with the help of the non-medical home care agency, found a conservator to help manage whatever money, if she had, just to manage that piece of it, because she did not have capacity to do so. I continue to see her. It's been over 3 years. She lives in an assisted living, in the same assisted living community. We provide oversight, helping her to live her best life. And I'll tell you that means to her is that she has a safe place to live. She is so happy there. I just saw her the other day. I just love it here. They're so nice to me. That is what's important to her. She knows that her son is gone, and she's also a widow, and she knows that her husband is gone. But for Sally, healthy aging, successful aging is being able to know that she has a safe place to live and that there are people there that care about her. I want to talk to you about another type of person, that we work with. And this is different. This is a young man who had a head trauma due to an automobile accident and is developmentally disabled. He has a guardian and a conservator in another part of the state. And while he was living in another part of the state, the care manager that actually also acted as his guardian was retiring. So she had to petition to find another guardian because she wasn't going to be doing this work any longer, but she still wanted the role of a care manager, an independent set of eyes and ears to help him make the transition to where he lives now in a group home. And that is one of the young men that we're working with right now. We provide oversight, coordination of services, advocacy with the folks in his group home. We assist with talking about person-centered, what's important to him. I'm going to call him Dave. Dave loves personal training and being a part of competitions. He enjoys learning new skills like bowling, archery, painting. We help him arrange vacations by brainstorming with him and his interests and including him in the details, what it is that he wants to do. We have a non-medical home care agency that also supports him in actualizing these dreams that he has. We advocate when needed. We help him purchase things for others, like flowers for his godmother or Christmas presents for close friends. We attend medical appointments with him. We collaborate with those involved in his care, like at the group home and the non-medical home care agency. We offer a listening ear to him when he's been hurt emotionally. We help him weigh the pros and cons of decisions while giving him the autonomy and the independence to make those decisions. We help to protect him from others who may take advantage of him by monitoring his bank account, his phone, and text logs. Those 8 core areas: crisis management, financial, legal, advocacy. Those are all a part of the work that we do with Dave. And my last illustration is about older adults, either single or couples who have no family support at all. But these are older adults who are healthy, living their best lives wherever they may be living, but they don't have anybody to serve as that advocate. There's no boots on the ground person because they don't have family members that either are living any longer. Maybe they don't have any children, or friends that want to take on that role. So we have a program called Safety Net, and that is specifically for the older adult who is, living their best life, but really wants a local advocate. For some of these people, we are appointed as the healthcare power of attorney if they don't have anybody else. For others, we are the eyes and ears for the healthcare power of attorney, and we'll jump in and advise should something happen. And how we work that program is through assessment. We meet with the person or the couple. We find out we have a whole medical toolkit where we collect all that important information because we're the formal support. We do an assessment, touch points throughout the year. We're accessible for an emergency. And at that point, we will coordinate services, we'll provide advocacy, decision support, all related to their goal of healthy aging as defined by them. Okay. Managing sooner than I thought. I practiced really slow at home, but whatever. Okay. I love the 10 tools to live your life well. We've been talking about them from the very beginning. So let's go through them. Connecting with others. Humans are social animals. We tend to do much better when we feel supported, valued, and understood. I mean, can you not agree with that, right? We do. And the research does suggest that people who feel connected are happier and healthier and may even live longer. That beautiful photo that you had, Director Munn, of all those people at the Lizard's Thicket, my very first experience with a Southern restaurant when I moved here. That's another story. I think really speaks to that, how happy people looked sharing a meal together. Staying positive, thinking negatively can drag down your mood and your health. But don't let that worry you, because experts say you can learn to be less gloomy. People who regularly focus on the positives in their lives are less upset by painful memories. I think that's part of that whole gratitude, for which I believe in strongly. Get physically active. Have we heard that before? Our bodies are built to move. And when they're pumping out stress-induced hormones, it really does speak to it. It boosts our mood. Exercise can help prevent heart disease, relieve insomnia, and reduce anxiety and depression. Help others. If you help your neighbor, it's good for her, but it's good for you too. If you do good, you feel good. And research suggests that those who consistently help other people experience less depression, greater calm, and fewer pains. Gandhi said, the best way to find yourself is to lose yourself in the service of others. I do a Meals on Wheels route once a month. And it seems like that one Thursday is always the rainiest day of the week. So I go out with my raincoat and my boots and my mask. I'm totally covered up. And I always look at the day before, is it gonna rain exactly at this time, and usually it does. But I can tell you that no matter how hard it's raining, it's much better if it's sunny, but no matter how hard it may be raining, I feel amazing after I deliver those meals. So if you're not already volunteering for Meals on Wheels, do it, because it'll be the best thing you've ever done, or one of the best things you've ever done. Get enough rest. Sleep may seem like a waste of time. Not to me, I love to sleep when there's so much to do, but you are more likely to succeed at your tasks if you get enough rest. Now, students, I don't know about you. I remember staying up all night trying to study for something, and I was up late last night going over this. So I get that, but you know what? You don't want to have a deficit of sleep. People who don't get enough sleep face a number of possible risks, including weight gain, decreased memory, impaired driving, and heart problems. Create joy and satisfaction. All right, I don't know what that means to you, and maybe you can tell me, but go ahead, kick up your heels or just kick back. For me, listening to Motown brings me joy and satisfaction. And if I put on some good music, I feel better. Do you all love music? And whatever it is that drives you, that creates joy and satisfaction. It's good for you. Positive emotions can boost your ability to bounce back from stress. Eat well, even at the lizard thicket or thicket lizard, whatever it's called. Our bodies and our brains need good fuel to function well. So eating healthy foods can boost your energy, lower the risk of developing certain diseases, and influence your mood. I did have some blueberries this morning. How many of you did? They're good for you. Good. Take care of your spirit. Taking care of your spirit means connecting to whatever you consider meaningful and holy, whether it's God, whether it's nature or art or something deep within yourself. People who have strong spiritual lives may be healthier and live longer because spirituality seems to cut the stress that can contribute to disease. Having something to believe in. Develop healthy coping skills or deal better with difficult or hard times. And most of us, if we haven't already, will face some particularly tough times in our lives. Having ways to cope with these challenges can protect your health and your well-being. People coping with stress feel less depressed after problem solving. And sometimes that means asking for help and being open to others that want to help you. So get professional help if you need it. If the problems in your life are stopping you from functioning well or feeling good, getting professional help can make a difference. Feel better because more than 80% of people who are treated for depression improve. Oh, I did want to say one thing. Okay, so that's me, but I do wish you all good health and healthy, successful aging, however you define it for yourself. And I thought maybe one of the things that I do with my support groups that I would like to do with all of you, if you would indulge me, is a breathing exercise, okay? So I want you, and I'm going to close my eyes too, or I might peek to make sure that you are, but put your feet flat on the ground, because when you're feeling stressed and you've got so many things that are just all the chatter and competing in your mind, you really need to take a breath, and that to bring you back to now, because you know there are 3 days to think about. Yesterday, which already happened, tomorrow, which isn't here yet, but today, which is the present, right? So close your eyes, and I will cue you on this. Breathe in through your nose through the count of 5, 2, 3, 4, 5. Hold that breath. 2, 3, 4, 5. Release that breath. 2, 3, 4, 5. Let's do it one more time. Breathe in. 2, 3, 4, 5. Hold. 2, 3, 4, 5. And release. 2, 3, 4, 5. Do you feel calm? I do, just from doing that. I should have done it before I started talking. Take good care of yourselves and each other. Thank you very much. And that's it. Oh, yes, sure. Hopefully, you can answer them. Are there any questions? Oh, yes.
I wanted to know about your payment source. I mean, if people want those services, how do they pay for that?
Yeah. So we are a concierge service. We don't accept any insurance, but some long-term care insurance policies do pay for care coordination. So it is a very specific niche group of men and women who utilize our services. And I had a long conversation with Anne Marie and Dr. Benge about that to make sure that, you know, it is specific to people that can manage that. But I use a lot of community resources. Thank you very much for your time. And I have some information if you are interested, I'd be happy to share with you.
Thank you so much, Bonnie, for encouraging us on how to live life well as the powerful resource and benefit that social workers provide in our community. So for the next hour, you get to chat more amongst yourselves and learn more. We have 6 different research posters in the back that are part of our Center for Community and Global Health. So we have a wide variety of research we do. Healthy aging is our topic for the symposium this year and next year. And then we also have lunch out here to the side. So feel free to, in any order, look at our research posters and talk with our students who have participated in the research with us and enjoy lunch.
All right, we're here with Ashley and Emily Hubbard to hear about the research that they're doing. Yes.
Looking at how the homeless population is bigger than the rest of the population, and with that comes an earlier onset of chronic conditions, specifically they're looking at literature review of using its experts. Yeah, kind of that overview. So specifically,
Let me come over here so they can hear you better.
we're doing rheumatic diseases. And, oh yeah, I can talk about it. Of course. So age homelessness, basically what that means is these people are in a cycle of homelessness. And they are facing premature aging, not so much your biological, but your chronic aging. So you can see someone who's 50 years old in age, but the way that your body functions, the way that you appear, is 70 years old. So it's an incredibly, it's a detrimental thing for your social, your emotional, mental, spiritual well-being. And then for results that we found, this, as you can see, we have a chart just from 2019. And this was a study done from the University of San Francisco in California, just looking at some determinants of that. And as results from that, arthritis was most commonly seen in rheumatic diseases. And then there was an increased prevalence of falls, specifically in women. And that's just due basically to arthritis and osteoporosis, as women are most notably seen with, due to the way that our bodies are made. And then a lot of connective tissue disorders. And of course, that's going to come with rheumatic diseases because it is a connective tissue issue. And these are affecting the joints. It comes with chronic pain, which is debilitating for these individuals who are experiencing it. And it really just takes them into a special niche of how do they get out of it, which then brings us to this, which was, it's really kind of looking at it from top to bottom view. Homeless being past or present, looking at the living conditions, premature aging, comorbidities, all of that on the same playing field, leading into them developing these rheumatic diseases. And again, are they experiencing falls? Are they experiencing the chronic pain, the functional impairment? And sadly, most of the time it leads to premature death. And we're just trying to find the opportunities to do this research from this paper to see how we can help these individuals and these families get out of that and help them, especially not just physically, but the medically as well. Yeah.
Are there any questions about this? Thanks, guys. We appreciate it. We are here with Tassi and Chris to talk about their research project that they've been working on.
So what we have here,
are y'all able to hear? Yes, they're able to hear.
Okay. So what we have here today is a validation study on a new food frequency questionnaire. And this is measuring the calcium intake in elderly Ivorian populations. So this study was done in Ivory Coast, West Africa, with the lead investigator, Dr. Bernard Kadio. And so what we have here is a food questionnaire distributed in the 24-hour sequence over a 12-month span. And we are just wanting to see the reproducibility and the reliability of this test.
So for a food frequency questionnaire, we're just trying to see if this is applicable to a larger population as a whole. What is that? All right, so we're trying to see if it's applicable to a larger population, and that's why we analyze reproducibility and reliability. And you can see in that bottom middle graph regarding to reliability, what it is just showing all of our data points as it's distributed over like the calcium intake. And what our instrument does, it tends to underestimate the higher calcium intake levels and overestimate the lower calcium intake levels. But that's actually okay, because for prostate cancer and calcium intake, we're looking more towards the higher levels. So it's okay if it underestimates it a bit, because we already know that it's already high. For reproducibility, we're really only looking at this value right here. It's called an intraclass correlation coefficient. And when you compare that to other studies that are evaluating food frequency questionnaires, a value around 0.6 to 0.7, anywhere around that value, that's looking at to moderate to high reproducibility. And so that's really what we're looking for in our analysis of the results. And then in our conclusion, like I said, it has a moderate coefficient of reproducibility. And because it is reproducible and reliable, we can use this in a larger study as a whole. This will be used in a study of about 5,000 people. Like Tassi said, our original study was only around 100, but now we can introduce this into a much larger population. And as you can see down here, this can be used as a measurement showing the correlation between increased calcium intake and a disease such as prostate cancer. And so that's our results. And Dr. Kadio is going to be doing more research on this later, and I'm sure this will be something we'll present on in the future.
Thanks, guys. All right, here we are at effects of aerobic training on vocal performance. And we'll hand it over to Katie to start the description of the study.
Yep. Hi, my name is Katie Butler. This study was a pilot study which looked at the effect that aerobic training would have on the vocal performance of college-age seniors here at school. What prompted us to do this study was the fact that there's an abundance of evidence on technique, but there's very little evidence on how aerobic training would affect the vocal performance. We sought to look at specifically how the exercise would increase their breath support, vocal intensity, vocal resilience, and endurance. What made this study a little bit cooler than some others is the fact that it was an interprofessional study. So we looked, the different departments here at school that were involved was vocal performance, communication disorders, and then the exercise science department. So for our methods, we looked at voice measures and physiological measures, and then we had our exercise training protocol. I'm going to hand this off to Kaylee, who will describe the vocal measures.
So for the vocal measures, we looked at a variety of things. A lot of things were obviously with aerobic breathing and vocal intensity and how the aerobic exercise impacted their disability for more endurance, to speak louder, to sing louder. And then afterwards, we also did a singing voice handicap index that measured things like their vocal fatigue and how much time they needed for rest because of that fatigue. And the main three things that we saw a significant improvement in was the spoken E and the singing low to mid-range E. And then also their singing voice handicap index also improved significantly. So they saw less fatigue in their voice, and that all goes back to them having the muscles that they needed to, or stronger muscles to help their breathing while they're singing.
Thank you so much.
I'm Scotty Wendell, and this is Leanna Harry, and we did a comparative analysis on data of the opioid crisis. So basically what we did was we compared overdose rates from 1990 to 2000 to overdose rates from 2010 to 2020. And we purely did accidental overdoses, not overdoses connected with suicide or self-inflicted harm. And what we see is a steady increase in 1990 to 2000 in overdoses at a pretty slow rate. And then in 2010, we see a dramatic spike in overdoses. And this spike continues all the way up to 2018, where we saw a small dip. And then in 2020, we saw the highest numbers in opioid overdoses that we've ever seen. Now, what we found through our study is that these overdose rates were highly correlated to areas with high opioid prescribing practices. So we compared by state the rates of opioid dispensing. And in 2012, you have a number of states which have over 107 prescriptions per 100 people. So that's a prescription per person and more. And looking 5 years down the road, these same areas with the high rates of opioid prescriptions and dispensing are the same states seeing high rates of overdoses. So these high rates of overdoses initially came from high rates of opioids being prescribed for common conditions, whereas normally opioids would just be prescribed for terminal illnesses or cancer. But today we see opioids being prescribed for things as simple as lower back pain. So they became highly distributed. And a couple years down the road, these prescriptions ran out, insurance ran out, and you have a large segment of the population turning to illegal illicit opioids from these prescriptions. And that's where we see these overdoses, is people seeking out alternatives that are cut with things sometimes 50 times stronger than heroin, something like fentanyl. And this is where we see the highest rates of overdoses.
Thanks, Scott.
Definitely.
Thanks, Leanna.
Hello, my name is Jacob Garrett. I'm a senior kinesiology student. This is Autumn Tuck. She's a freshman kinesiology student. And then over here is Abigail Miller. She's a junior pre-med. And so our research study here is on the relationship between self-reported fatigue and balance in the elderly. And so what we're looking at here is based on how they report their fatigue in their everyday life. We're looking at how that correlates to their results here on the Biodex balance machine. So the Biodex balance machine is kind of our niche in fatigue and balance. And really, it's modern technology that's really awesome that looks at, sway velocity, sway index, which are very important factors in balance. As well as really the musculoskeletal efficiency of a person in terms as it relates to their balance. And so we do several tests here. So we have a couple of questionnaires really that looks at, their fall history, and then obviously their fatigue, which is self-reported. And then a couple of the actual tests that we'll do are several tests in the Biodex balance machine. So first we have the fall risk test, which really looks at the postural sway velocity. And so what sway velocity is basically when a person is standing still or attempting to, there's going to be a slight amount of sway there that you don't really even recognize. And so this machine captures all of that and gives us a look at that, which sway really shows us how they're doing in their balance. And so then you have the motor control test, which is depicted right here. And so the motor control test is really cool in that it shows us the musculoskeletal efficiency as it relates to every direction that a person might be prompted towards. So as we can see here on this one, the person here, their least efficiency was on backwards left. And so, based on that, as it stands right now for this person, backwards left would be the most risk for them at falling. And so, what we can do then with this is look at maybe like the lowest 3 efficiency levels here, and then really practice those and get those areas nice and secure with like a motor control training here, where they kind of move the cursor to those specific bubbles, which really trains those muscles in those directions. So then we can decrease that risk of falling in those specific areas. And so, it's an ongoing study. So we don't have concrete conclusions yet, but we're looking forward to in the future, the next couple of months, to really see how fatigue, specifically self-reported fatigue, relates to the different variables of balance that we can get here on the Biodex balance machine. So yeah, that's our poster.
Thanks, Jacob.
Yep.
Thanks, guys.
Hello, everyone. Thank you very much for this invitation and this opportunity to talk to you about the Life Research Institute. My name is Linda Garcia. I am the founding director and a full professor at the University of Ottawa in Ottawa, Canada. I've been asked to tell you a little bit about what we have at the University of Ottawa, an institute focused on aging called the Life Research Institute. So this institute got its initial idea from the Faculty of Health Sciences in terms of a strategic direction. We were asked to look around and see what we could put together that would be a little bit innovative, I guess, with regards to aging. So they told us, the experts told us to look at the complexity of aging as well as change over time. And so this is what we focused on. We're very interested in the complex issues surrounding aging. We partnered up with the ILC Canada, the International Longevity Centers, which is part of a global alliance of about 16 countries, and they're advocates for older adults. And then we did an internal validation to see if the people at the University of Ottawa would be interested in such an institute. The official documents were prepared in 2018, and I became its first director in 2019. My mandate ends in 2023. The concept, of course, is that aging is not part of life, it is life. And what we want to do is to bring researchers and partners together to look at the trajectories of life. So how do you end up where you end up in older age? And bringing together people from all kinds of faculties to try to understand that trajectory. We have pretty well 3 pillars, one that's related to living long, living well, and living with voice and choice. And as you can see, the blue writing that you see under these pillars are actually faculties with which our co-leads are associated. So you can see that we have people from engineering and medicine and Telford, which is our management school, and the Faculty of Arts and Health Sciences and so on. We also have some governance structure that allows us to focus on research and learning. And those are both committees that advise the steering committee who actually makes decisions. And they're also receiving input from our advisory committee, which is a high-powered committee that comes and meets twice a year. So on that, we have 4 deans from 4 different faculties. We have people from outside, including Jean Asius, who's with AARP. And we also have people from Switzerland and some experts in aging, as well as people from the private sector and an ex-politician. The colors that you see on this slide basically relate back to the fact of pointing out that we do have people who are from a whole bunch of different faculties, and that's reflected in this slide as well. So this is the breakup. We have 128 members now, of which about 80 and 90 are academics. And you can see by the colors here that they do come from different faculties. So we've come together to look at the complexity of aging. When we asked our members what they wanted to know and why they were members of the Life Research Institute, they told us they wanted to network and collaborate. They wanted to highlight their research. They wanted to engage students as well as find funding. So we've been working on that very solidly to try to give them what they want. So the Life Research Institute is designed to link. So we've put together these breakfasts around these themes that you see on this slide: nutrition, housing, self-care, mobility, communication, interpersonal relationships. So we're putting at the center the aging individual, and we're bringing together faculties and members and linking them to try to address these issues. So to give you an example, if you look at housing, where we live, what we use as shelter, and how we develop these places into homes is fundamental to our ability to live long, live well, and with choice. But we don't all have a home, and some of us have a harder time in our homes than others. So we look at how can our research and our knowledge, and how can we mobilize this at the Life Research Institute to address issues of housing around older adults. The Institute, the I stands for investigate. So we have international collaborations, private and public partners around a whole slew of areas, and people bring expertise around epigenetics and cellular aging and healthcare systems and technology and indigenous communities and intergenerational expertise and ageism and so on. We bring them around the table to address projects, and we try to fuse those. So this is the F in life, to fuse the ideas. And it's not enough to just link people, we need to connect them. So we're connecting them for research and learning. So one example of that is a dementia inclusive air travel, where we bring together an expert researcher on consumer behavior along with experts in regulations and security and health sciences and disability law and design to try to look how people with dementia can better travel through using the air, through the air industry, basically. And finally, the E in life stands for educate. So we support learning in all age groups and in all sectors through collaborations and so on. And so we've been involved with the ILC Canada on the UN Convention for the Rights of Older Adults. We've had a dialogue around Does Age Matter, when students from different faculties talk about housing and health and work and leisure and technology. And of course, we have some scholarships for our students as well. So thank you very much for listening. Thank you for your interest in the Life Research Institute. This is our website. You can follow us on Twitter and LinkedIn. We're starting to get a little bit more active. We've only been in true existence for about 4 years, so we're moving as quickly as we can. Please reach out and have a great day, everyone. Thank you so much. Bye.
Good afternoon. We are now ready to start the second part of our symposium. And we'd like to welcome back our online participants, as well as all of the wonderful individuals able to join us in person. We hope you enjoyed the break and learned more about the Center for Community and Global Health, various research interests. This afternoon, we look forward to discussing in a more in-depth manner 2 of our current research projects focusing on healthy aging. But before we share those projects, we are privileged to have Dr. Valerie Peterson, who brings great joy and good morale to our School of Health Professions, but is also part of our nursing faculty, a family nurse practitioner, and a certified gerontologist to share about the physiology of aging. Please join me in welcoming her.
All that to say, they gave me the esteemed pleasure of speaking to you after lunch. I do have my master's in clinical gerontology. And so I like to say I have my master's in old people, but the closer I get to that magical age that somebody decided of 65, I don't know if I'll continue referring to myself as that, but we'll see. What we're going to talk about today is basically things that will help you as you're aging, and if you're caring for an elderly loved one, some of the changes that happen during the aging process and what kind of safety issues that can occur with those. That's my sweet mama and me pinning a corsage. She just recently died a year ago and had strokes and almost died when she was 35 years old and pregnant with my youngest brother. Ended up with dementia, but lived to be 82 years old. Okay, there's some things that affect how you age. You would agree with that. How many of you know somebody that's 80 or 90 that runs circles around you as a younger person, right? How many of you know somebody that's 60 that, oh, I can't do that, I'm too old? Okay, exactly. So you've got lots of things that affect it. Attitudes, physical activity, nutrition, personal habits, and physical illness, okay? When we say personal habits, what does that usually mean? What can affect you aging? I'm all for audience participation. And I need to be able to walk. Can I take this microphone out? Oh, good. I can't stand here at this microphone. Maybe I can. Okay, I've got to stay here. That's going to be the hardest part. Personal habits, basically smoking, alcohol. Ooh, Dr. Kadio, he's bringing me a microphone so I can walk around. Oh. No, but I wanted it for myself, but she's telling me I have to stand here. Okay. Thank you anyway. Okay, I'll try. If you've met somebody that has smoked many years, they are going to always look 10 years old, at least older than what they should. It really tears apart your body. So that's one of the variables. But again, like we said, there's lots of different things. And so I love this quotation as far as chronological age is not physical age and is thus a poor criterion for determining when old age begins. Unfortunately, the myth of chronological aging is believed by many. Many people envision old age as a time of helplessness and dependency, loss of physical mobility and mental alertness, and general lack of interest in life. All of those things basically are ageism. And you saw that term on some of the slides previously, just the one that the lady just talked about for the 5 minutes before this. We don't want to put people in, a box, because as we get older, it doesn't mean that we fall into this category. Henry Wadsworth Longfellow also put it quite nicely, saying, "For age is opportunity no less than youth itself, though in another dress. And as evening twilight fades away, the sky is filled with stars invisible by day." How many of you love the night sky? How many of you are out on your backs in your front yard when there's ever a meteor shower like I am? Yeah, I often wonder, people driving by, why are those two people lying in the front yard in the middle of the night? Should we stop? Is it a murder? But no, just star looking. And the beautiful sky, we can only see at nighttime. And so as we age and get older, there are certain things that, we don't have as a younger person that we get. How many of you have grandparents that have wisdom that you will never have, because of gaining that throughout their age? Okay, as far as the physiological changes in the aging process, I'm going to start with the 5 senses. Okay, so we'll start with your vision. And basically there are these 3 or 4 different disease processes that happen a lot of times to our vision as we get older. Have you heard of senile macular degeneration? Who knows what part of the vision that you lose if you have that? The central vision. Okay, so imagine having to see only the outside. There goes my tea. I'm just begging for attention, right? Sorry. It's covered though, but thank you. Senile macular degeneration. Thank you. Move it over here so I can knock it off the other side, right? And there's certain genetic variants that can cause that. Associated with the disease, also eating foods with high glycemic index. Look at all those. None of you like any of those foods listed there, right? Cookies, cake, candy, pizza. Well, we'll have to put a few of them away. All right. And then diabetic retinopathy. And because of some of the changes related to our endocrine system and not metabolizing our glucose as well, then it falls to reason that diabetic retinopathy also increases as we get older. Cataracts, y'all have heard of cataracts. Oh, it was the day of my demise when I went into the eye doctor. It was a couple of years ago. I see some cataracts are start forming. I'm like, what? I get that can't be already. And didn't even tell anybody for I don't know how long, because I thought this is just too much for me. But anyway, that's normal for that to happen. Glaucoma, the condition where the pressure is too high in your eyes, a lot of time will happen with aging. And this is normal aging for everybody. The term is presbyopia or farsightedness, okay? You can always tell that somebody is over 40 years old because this is how they're holding their reading material, okay? So if you don't want somebody to know you're over 40, just hold it here whether you can see it or not, because presbyopia makes you do this, okay? But you could just go to the drugstore, Walmart, wherever, and get those corrective lenses. And you don't even have to go to the eye doctor for that, okay? Also, the lacrimal glands atrophy, the lens becomes more opaque, pupils become more rigid. And you're like, well, why do I even care? Well, dry eyes, blurred vision, it's going to put people more at risk for falls. A lot of these things are. The cornea not being able to differentiate colors, even simple things like decorating, you may want to take this into consideration. When does that last one cause a problem? The pupils taking longer to adapt to light and darkness. Driving is absolutely right. I hate to say I was driving at night last night and I'm like, no, I'm here. I'm old. My pupils are taking longer to dilate and constrict. It's really rough doing this lecture year after year because you see yourself closer and closer to fitting into it. Okay, glare is more pronounced. Now, this isn't as much as what used to be later, but the glare, facilities want to have bright, shiny floors. We don't want that. Okay, because that puts them more at risk for falls. It just goes back to your face. Check this out. Need more intense light to see. Older people need 4 times more intense light than younger people do in order to see. Okay, depth perception decreases. So stairs, walking down stairs and things like that. Contrast sensitivity. Eyes see deeper into the orbit. The reason I mention that is because when you're standing over a person, when that has happened, the eyes sink deeper. You don't want them having to go like this to see you. Just take it into consideration to meet them where they are. And then corneal sensitivity decreased. If an elderly person gets their eye scratched or something, you do want to take them to the eye doctor because it may not hurt as much as what a younger person. All right, hearing loss. It can either be sensory, neural, or both. It can be conductive, sensory, neural, or mixed. Okay, and conductive means whatever is the sound trying to get into the ear before it hits all of the nerves. Okay, what kind of problems those might be. Then, or is there like the problem right in there with the nerves that are interpreting it to the brain as far as the sound, or a mixture of both? Now, with elderly people, our glands that, well, glands for lack of a better term, that make the cerumen or wax don't work as well. And so it tends to build up in the ear canal. If you have someone that you're caring for and you notice, man, they can't hear a thing, and maybe they just were able to hear a couple of months ago, first thing to have somebody do is look into those ears. I have honestly seen things like as big around as a pencil and like maybe an inch long pulled out of somebody's ear, you know, and the other ear. And it's like, oh yeah, they heard a whole lot better after we got that out, and no problems whatsoever after that. Also increased hair growth and thickness. I think it's on the next slide that I have that. But we'll talk about the term that's for the, that goes along with like presbyopia with the vision is presbycusis with the hearing. So that's the loss of high-pitched sounds and voices. So be careful to not talk that way. And what do we do? Oh, hi, Grandma, how are you today? Well, don't do that because they lose the ability to hear some of those high-pitched sounds and voices. And I always think of our anatomy and physiology teachers like Dr. Chetta sitting there. When I hear the term organ of Corti, you know, that just sounds so anatomy and physiology, dragging me back to all those years. That and the circle of Willis, there's just something about it. Okay, so I get the hairs that I was referring to in the ears, there's actually a term for that. So if you're playing Wordle, it's tragi, T-R-A-G-I. So just that's free. All right. So some tips for compensating. You want to speak slowly and distinctly and directly. And again, try to speak in a regular tone rather than a high pitched, because they tend to lose those high pitched sounds. Give them adequate response time. How many times have we asked somebody a question and then before they had time to answer, we're walking past them and on to the next thing? If they can't hear what you're saying, rephrase it, because you may use after like some of the other letters that aren't considered high-pitched sounds, and they might be able to hear it better. Okay, speak before touching so you don't scare them up out of their wheelchairs. If they need to use gestures or be given pad and pencil to help, you'll always want to take that into consideration as well. Here's another exciting word, hypogeusia, lack of taste. And it's really kind of, well, the literature doesn't agree as whether how much sense of taste that we lose or don't lose. But there is a certain amount that will. The most things that are most important as far as safety-wise related to the mouth and taking in of food is decreased sensation to hot and cold. So you want to be really careful before you give them drinks that are too hot, that they don't burn themselves. And then the most important, decreased thirst sensation as we get older. It's not enough just to have water in the environment. You want to offer fluids to that older person, like every couple of hours or whatever, to make sure that they're getting enough. Any questions yet? I don't like to stand up here and talk without it. Anybody have any questions? No? All right. Now the sense of smell, there are some atrophic changes in the membranes, but basically changes in the sense of smell are attributed more to environmental factors like pollution, smoking, things like that. And then as far as touch, the last of our 5 senses, loss of collagen or like the building block kind of things related to our tissue, increased capillary fragility. That means that the blood vessels break easier. So what does that cause with our elderly people more frequently than younger people? Bruising. But everybody thinks grandma's been abused in the nursing home because she has all these bruised. Okay, so you need to be aware of this. You need to look into situations where someone's having bruising, but obviously it's not going to be every time somebody's being mistreated, because normal aging produces these capillaries that are more fragile. And also the dermis is less elastic. Have you guys heard of skin turgor, testing that for dehydration? Well, an older person, you should not check it on their hand, their arms. You should do on their clavicle, forehead, sternum, something like that to check for skin turgor. Because you know how you pull up an old, and I see if mine stays, then I'm officially old, right? You pull up an old person's hand and it stays there. That's called tenting. But because our skin is less elastic, that's the reason why it stays. And that's why you should check it on one of those other 3 places. It's really kind of funny when you say, I'm going to check see how your skin is. I'm going to pinch your forehead. Well, whatever you want to do, honey, because it's kind of a crazy little request to pinch somebody's forehead. Subcutaneous tissue decreases in the extremities, so there's not as much to keep us warm. Decrease in sebaceous glands, and then that can produce their skin is going to be more fragile as well. So they need to have moisture, lotion and everything applied more frequently. Why in the world did I include that we lose our hair? What does that, who cares? Is that just rubbing salt in the wound? Well, no, because you stop and think, we lose a lot of our heat out of our heads. And so you want to take that into consideration when people are outside, to get that hat on if it's cold out. Atrophy of sweat glands. How many of you have been to a high school graduation and an old person is taken out by an ambulance because they passed out during the outside graduation? It always happens. We don't sweat as well and keep our bodies as cool. And then there's actual changes that impede the sensory function of our skin. So we want to take that into consideration as well. Any questions about the 5 senses? You guys are good? Okay. Basically with the heart, this is a scary thought here. You all are, it's not just me getting old, it's all of you too. Cardiovascular risk doubles every 10 years past the age of 40. There's probably some people in here past the age of 40, right? Then what happens with the cardiovascular system is all of the valves and blood vessels and everything basically gets stiffer, okay? And that's why a lot of times people's blood pressure will go up, is because it's harder for the blood to go through those stiffer blood vessels. Does that mean that it's okay for our older people to have blood pressures of 160, 170 over 100? No. You still want to bring that down to a level that would be good for them and not just write it off to, oh, well, they're old. What do you expect? Decrease smaller cardiac output, reduce stroke volume, organs receive less blood, pacemaker cells, that make your heart do the beating that it does. All of these things happen as we get older related to our heart. Decreased elasticity in myocardium. The next one we all experience too, baroreceptor response. How many of you have stood up way too fast? And you're like, whoa. That's the baroreceptor response, is what keeps you from falling over on your face. And as we get older, that doesn't work as well either. Less elasticity, we've mentioned as far as the blood vessels. Decrease in serum albumin puts their skin at risk too. If you don't have enough protein, you're more likely to get pressure ulcers. Decreased platelets, and again, that can make problems as far as related to the skin. Aorta thickens and becomes stiffer, so everything just gets stiffer. It's not just all of our bones and muscles, it's like everything. Okay, breathing, decreased gag reflex. Well, how many times you've had that tongue blade put in your mouth and you go, well, that's a good thing. We all need the gag reflex to protect our airways, okay? And as we get older, it doesn't work as well. So that puts people more at risk for what's called aspiration, of getting like food or fluids down into your lungs. and food and fluids do not belong in our lungs. That does not do well in our lungs. So we want to take that into consideration as well. Also, the diameter of the trachea and the central airways increase as well. So we put that on top of the gag reflex not working as well, and you have double trouble. Decreased compliance of the chest wall, alveolar structure changes. So again, a lot of this boils down to, things are getting older, aren't working as well. You're not going to have as much input as far as with your respirations. This is a kind of scary one to me. Airways tend to collapse when breathing in low volume and in a supine position. I was like, I never want to sleep on my back again. My airways will collapse. But all of these changes are considered normal aging. The second one there, as far as lowered oxygen content and increased carbon dioxide, they don't respond as well to those things as what a younger person would. And just loss of the elasticity of the recoil of the lungs, all of these things that we don't even think about daily as we're breathing that can happen. Okay, neurological changes. They told me I only had 30 minutes, so that's why I'm trying to talk really fast. A lot of things do happen with the neurological system. There's degeneration in the vascularity to the system and decrease of the nerve conduction and the neurotransmitters. I just always picture little things in your body and like the messages are jumping from one to the next. Well, as we get older, that message business slows down. So that tends to cause some problems that we're aware of. What can you think of as far as if the messages are slowing down between transmitters, where is that a real safety issue? It's the same answer as the pupils getting more rigid. Driving, yeah. Because when Dr. Chet is driving 85 down the highway and we don't know he's driving that fast and we pull out, now you don't drive that fast ever, do you? Never. Okay. Increased frequency of waking at night and decreased number of brain cells or neurons. And you're thinking, oh, well, this doesn't sound very promising. Well, and then less REM sleep, which is the rapid eye movement or the dreaming sleep. How many can attest to decrease in short-term memory? All right, well, problem-solving skills kind of decline. Verbal skills can remain constant or even improve, okay? Don't try doing the New York Times crossword puzzle with grandma. Don't, you'll lose. And then autonomic nervous system is less efficient, okay? That's the part of your nervous system that keeps everything going, again, that you don't have to think about. And then as far as the world population, approximately 15 to 20%, 65 and above manifest mild cognitive impairment, but that is not considered a normal part of aging as far as dementia, okay? Memory retrieval is a frequent complaint. Speech, language, and procedural memory might even improve though, so there's give and take there. If you want to live long and live well, there's the answer right there. It's always the right answer, diet and exercise. You could just stay home if you knew diet and exercise. I compare this to when I went to a seminar. Anybody been to an infection control seminar? Anyway, for like all day long, 2 days, how many ever days? But what does it boil down to? Wash your hands. Just stay home and wash your hands, okay? All right, so even with all of these changes in our neurological system, at this point, and I don't have the proper equipment or proper clothes on to do this, but in front of the classroom, I get up on the desk and tell the students, confusion is never a sign of normal aging, and increased confusion over a short period of time is never a part of dementia. This is the most important thing that I'm going to say all day long. I would say that anybody's going to say all day long, but that might be a little too haughty or whatever the word might be. But if your old person is confused, that is an emergency. Do not write it off to, oh, they're old. That is ageism, okay? Find out why. You'll be able to diagnose most of the time by saying, I bet they have a urinary tract infection. I had a nursing student diagnose the microbiology teacher's mother's problem in the nursing home by saying, she probably has a UTI from the audience in the classroom. And that's what it was, believe it or not. Okay, so I can't stress that enough. Oh, I looked down, it says 170 slides, but that's everybody's about that heart attack. I'm like, where am I? Am I present? 170. No, we're not going that far. Okay. As we get older, our immune systems don't work as well. There's a T cell and B cell imbalance that happens. And this is another very important thing with the elderly. Lack of temperature does not mean that there's not an infection. Okay. If they have 99.4, then they could be very sick with that lower temperature because the older person's immune system doesn't work as well. Okay. If you wait till it's 101 or whatever, that's what I tell my students, you know what they're doing? Knocking on death's door if you wait that long for their temperature to go up. You've got to be in tune with that. Now, there was actually something done as far as I was telling the people at the table, a serendipitous finding of the calorie study was that there was a controlled group that ate the normal diet and another group that ate restricted calories. And when the restricted calorie group, one of the things they found was that the thymus gland actually increased in size, and the thymus gland is what produces those T cells. So it's kind of a theory that possibly by eating a less calorie diet, that you can actually improve your immune system because it boosts that production by the thymus. All right, now we all know the whoa, let me just jump too fast. The musculoskeletal changes. And now I'm going to hit absolutely everybody in the audience because nobody in here is younger than 20, right? Did you know that you lose a ½ an inch every 20 years, beginning between age 20 to 40? So anyway, everyone is included there. Spinal column shortens, decreased sense of balance, decreased coordination, compromised vital capacity, osteoporotic changes, enhanced sway. All of that to say it increases the risk for falls. Okay, so you really want to watch out for that. The other things, muscle atrophy, and some of this doesn't always have to happen. If you have an older person that stays active, I saw an article one time, instead of Rambo, it was Grambo, this mountain climbing lady that was like in her 70s, whatever, she's not going to have muscle atrophy. Okay, so if you stay active, that doesn't happen. I like this next normal sign of aging, increased abdominal girth. You can just say, I'm having a little problems with increased abdominal girth, and people will never know. They'll feel sorry for you. Weight decrease tends to happen. Strength and endurance may decrease. And once again, everything just gets stiffer and it's more difficult. That's why you see the wider kind of shuffling gait. Not like Tim Conway. Those of you that are old enough to remember Tim Conway's shuffling gait. That would probably be closer to Parkinson's, which is another discussion. Okay, muscle capillaries less dense. We've got problems as far as the total body water. Younger people will have more water, older people have less water in their bodies. And so that can really cause problems with medications, getting too much medication in your body just because your body doesn't have enough water in it. So that's going to be something you'll watch for there. Now, as far as the GI system, stomach's going to shrink, liver decreases, atrophy of the mucosa and connective tissue in the large bowel. All that to say, sometimes you've heard of pernicious anemia, vitamin B12 problems that can be associated. That's a disease process, but it can be associated with that stomach size not being as large. The part about the connective tissue in the large bowel, constipation is not a normal part of aging, okay? It's common, but I don't want you to consider it normal, because what happens when we consider constipation an older part, like a natural part of aging, your person is dead 2 weeks later because they had cancer of the colon that nobody bothered to send them to get checked out for when they were complaining of constipation. Okay. You don't want to just rule it off to, oh, they're fine. Okay. And genitourinary, our kidneys don't work as well. But basically we do keep enough of our kidneys that most people, as we get older, we don't really have problems with that aspect. The one thing that we do have problems with is bladder capacity decreasing. So if you hear somebody that's saying, well, I just helped you to the bathroom, our bladder capacity decreases by half when we get older. So they should have to go to the bathroom twice as more frequently. Decreased sphincter control, and then some things that happen to men. The prostate tends to enlarge and will interfere with urination, and ladies increased risk for UTI because of some of the hormonal changes that happens. And then there's some basic general things that'll happen overall as far as ability to concentrate urine and response to the antidiuretic hormone. Okay. All right. Now, endocrine system, we talked about the ability to metabolize glucose and that getting diabetes is common as we get older, but we haven't mentioned the thyroid. If I said to you, okay, there's an 80-year-old woman and she's confused and tired and depressed. If you say to me, oh, well, what do you expect? She's an 80-year-old woman. However, confusion, fatigue, and depression are signs of hypothyroidism in the elderly. And all they need is one little pill of, thyroid medicine every day, and they'll be back and fine. Okay. And lastly, I just want us to remember this, that we don't want to forsake the elderly in their old age. We want to take care of them as best we can. And hopefully these little tidbits that I have shared with you will help you to remember what we do lose as we get over and older, and then ways that you can compensate for that. I don't know that we have time for questions, but does anybody have a burning question right now? Yes. Interesting. Interesting. Thank you for sharing that. Anybody else? Let's go get old.
That's for me, all right? Okay. All right, well, thank you, Valerie, for the presentation on the physiology of aging. And it may sound depressing to hear that changes occur with aging, but I would say that through the research that's going on, there are many things happening right now in the way trying to find a way to reduce the speed of aging. And that's really important in a way so people can continue to maintain the quality of life, but certainly there are many systems involved when we talk about aging. So this topic is analyzing age-related changes pertaining to fall risk and speech language abilities. I'm one of the presenters. I'm Stephen Chen. I'm a associate professor here at Bob Jones University, teach exercise science major students here. And my doctorate is in exercise physiology. And the second presenter is Dr. Hannah Benge. She is the assistant professor in the communication disorder department here at Bob Jones University as well. She has a clinical science doctorate degree in speech language pathology, and she also practices as a licensed speech language pathologist. Did I get all right? Yeah, good. So first I'll discuss about fall risk, and then Dr. Benge will come up and talk about cognition in relation to speech language abilities. So falls are a major public health problem nationally and globally. And so what is a fall exactly? Fall is defined as landing on the ground or somewhat of a lower level when you're not intended to do so. Okay. However, accidents that cause you to fall, whether you run into by somebody with a scooter or a shopping cart, or possibly because of a stroke, a seizure, or a paralysis, and it causing you to fall, that will not count as a fall. Okay, so that's a definition of fall here. So let's talk about the epidemiology of falls here in the United States today. About 1 in 4 Americans aged 65 and above report falling each year. Out of that stats you can see in this diagram, about 36 million of falls are reported each year. And not every fall that leads to injury, but certainly there are about 8 million older adults have suffered moderate to severe injuries. You can probably even already understand that there is injuries leads to hip fractures as a common one for the older adults, and they're primarily derived from falls. And also, fall is the #1 reason for these older adults to experience a traumatic brain injury as well. With the injuries that leads to many emergency department visits, hospitalizations. Now, when we think of falls, it's also very costly. And injuries due to falls that leads to hospitalization can cost $30,000. Look as a whole here in the United States, about $50 billion are spent in healthcare due to falls every year. And so about 75% of the costs are paid by the Medicare and Medicaid. Now, when you think about falls, you might just think about this injury. It may not necessarily lead to death. Again, if you look at the stats here, is that the falls are the #1 cause of unintentional injury deaths in older adults, 65 and above. So if you look at the stats, maybe about 32,000 older adults die from falls each year. That's about 88 older adults every day. And if you look at the stats across a 15-year span here from 2000 to 2016, a study published by Dr. Hartholt in JAMA showing the death rates from falls after adjusted for age increased by about 30%. From 2000 to 2016. So this is quite alarming. Okay. So as a population ages, as Director Munn had talked about earlier today about the statistics, you can expect that there'll be more falls and injuries if we don't continue to expand these efforts of promoting prevention programs, fall prevention programs across the state, across the nation. You can expect that number is going to continue to go up. And so there's a lot for us to do still in this regard. So falls are common, costly, and have serious consequences. But there's some good news. The good news is that falls are largely preventable. And besides programs and interventions, and there's a lot of education need to be involved, counseling as well, and for healthcare professionals to provide that to the clients. There is a study have done to look at the survey among older adults. About less than half of the older adults will not report their fall to the doctors for several reasons. #1, they think that it's because it's a normal aging process, and there's nothing they can do about that. Second of all would be possibly is because they fear talking about it to other people, to the doctors, in regard that they might be placed in a nursing home, and therefore the independence could be threatened. And then third reason would be because they're just not aware of these risk factors that are involved in the falls. So throughout the past 25 years or so of research, there's plenty of risk factors being established that is linked to falls. And certainly up here are the modifiable risk factors, and that really every healthcare professional should be aware of as they're doing the assessment on their clients and patients, and also for the seniors to know that what they are, what they can do to improve these risk factors. That would including gait strength and balance deficits. Even though that person can walk around without any assistance, that person might have an issue with their gait, possibly impaired balance. Medications used as well. There's some medications with the side effects can lead to fall as well. hypotension, vision problem, home hazards. That could be because of inadequate lighting, crowded hallways, and obstacles in the room, in a small room, foot issues and footwear, also with vitamin D deficiency as well. So there are many websites and many programs. What I found is under the CDC, Centers for Disease Control and Prevention, they have a fabulous website. And to provide toolkits, educational resources, videos, testimonials, and it's a very friendly website. And for healthcare providers, also for seniors to go on and learn about fall prevention. So the CDC came up with this initiative called STEADY, that stands for Stopping Early Accidents, Deaths, and Injuries Initiative. So again, in this initiative is to help healthcare providers to provide a framework to develop a fall prevention program. And this is just a snapshot of the chart to show you what STEADY is. And basically is to assess the individual's fall risk, as well as all the risk factors that I just talked about a few slides ago, and to make sure that every risk factor has been assessed, and then to come up with interventions in a way to improve these risk factors that person might have. So it's a fantastic chart to follow through, and as for any fall prevention program. Now, in my talk today, I do want to suggest to adding more risk factors in this chart. And so the two factors, the first one is fear of falling. Fear of falling is a persistent concern about falling. So there's numerous research so far have shown that about 20 to up to 60% of the community dwelling older adults have that fear of falling. Okay. And even without an injury, a fall can lead to the fear of falling as well. And so what does it matter to us? Well, the fear might stop somebody to become more active, might stop somebody from doing the things they love to do, and maybe they plan to do one as well. So again, other studies have shown that 20% up to 55% of the community dwelling older adults reported limited daily activities due to fear of falling. There's plenty of research in this area already, and very extensive research. And but this study published by Liu and back last year, and they were able to track these individuals in a longitudinal fashion for 5 years to look at the independent effect of fear of falling. Okay, so they're being compared to folks that have fall in the previous year, maybe multiple falls in previous years, and versus those that just have their fear of falling without any falls. Okay, but you will see is that in this 5-year data to look at mobility, self-care activities, and household activities, if you look at follow the green triangle, I'm colorblind, so I hope my color is right. So. And you can see that is exhibit a very similar negative consequences as far as increasing the percent of limiting mobility, the percent of limiting the self-care activities, as well as household activities. Okay, so this is really a tremendous results from this study show that independently, fear of falling can exhibit these adverse negative impacts on physical functioning. Another key point to highlight is that fear of falling can also be identified in older adults that have not fallen yet. So this is very important for us to know. And as we go through the screening, we do want to make sure this is included. But if you think of fear of falling based on the previous results, once they start limiting the activities, they start to develop deconditioning, the physical deconditioning. And then we talked about from the earlier talk about social interactions and social withdrawal. This is a big part of it. Now they're more isolated because they don't want to stay at home and they don't want to go out there and because of fear of falling. And that leads to reduced independence and also poor quality of life. So it is very important for healthcare providers to consider this as a risk factor in a way to come up with these questionnaire. There are actually several questionnaires that are validated to assess their concern, the level of concern about falling. So it's not just asking one question or two, but really as a validated questionnaire. It's a 16 questions for this. It's called the Falls Efficacy Scale International. And that allow really just a 10 minutes of assessment to find out the rating from 1 to 5, how concerned they are as far as doing things or inside, outside the home. Even though that they may not do the activities all, they ask them to think, what do you think your level of concern would be if you do this activity in the future? So the next risk factor I would want to mention is fatigue. Okay, fatigue is a complex, very complex phenomenon. In my area in exercise science, we study fatigue in regards to performance, sports performance. There's physical fatigue, maybe asking you to go up the hill, walking for 30 minutes, and you get fatigued physically. There's mental fatigue or cognitive fatigue, where you're asked to do an hour of crossword puzzle and you get the mental fatigue, or maybe studying for example 3 hours, you develop mental fatigue. But the fatigue I want to talk about today is defining as a subjective lack of physical and or mental energy, that sensation, okay, that is perceived by the individual that will interfere with the usual or desired activities. So it is one of the most common symptoms experienced by older adults. With the disease, for example, folks have cancer, they suffer depression, multiple sclerosis, arthritis. Fatigue is a key symptom of those chronic diseases. But also, based on the research in the past 15 years or so, fatigue is also found to be commonly in these older adults without chronic diseases. About 15 years ago or so, the NIA, the National Institute of Aging under NIH, they have come with the initiatives to study more about fatigue in the older population and how does it relate to physical functioning and also the causes of fatigue. Okay. So the research have shown so far is that the fatigue, the persistent feeling of tiredness, can affect up to about 50% of the community dwelling adults. And here you can see that has profound consequences as well on physical functioning. For example, in a large community of non-disabled individuals, the high level of fatigue rating is linked to limitations on daily activities, along with mobility disability, future hospitalization, increased utilization of home care help, linked to depression, also early mortality. So I just want to show you 2 studies. And this is a new area to link the perceived fatigue that we just talked about, and is that linked to fall risk. So there are a few studies that just came out in the past 3 years here, and really trying to promote that fatigue is a risk factor for falling that needs to be assessed. Here is a correlational study. It's a cross-section study published last year by Benge et al. And to look at the self-reported fatigue level in older women and older men. And they asked them to do a rating from 0 to 10 and to look at their fall history. So they basically stratified them into non-fallers and fallers for women and for men. And you can tell so far that is the results are the same in a way that if they rate themselves higher with the perceived fatigue, and those are the fallers. So those have fallen in the previous year, they have a higher level of that reported fatigue. Okay. And the next study is to track these individuals. This is a study of a larger scale. About 5,600 men were tracked for about 3 years or so. Very similar concept. They were asked to do a rating of fatigue. And then it's basically to the key goals of the study is to find out how is that related to the prospective fall risk if within the 3 years time span. So the results showing that is for those that rate themselves higher with that self-reported fatigue, they have a 25% chance increase in fall risk, okay, over the 3 years follow-up. which is also interesting as well, that it also found there's a 50% increased chance of recurring falling as well for those have rated themselves higher in that fatigue category within the first year. So again, based on these studies, we really ought to include these as risk factors. And there's so many of these things. It does require a lot of time, but I think falls is a complex phenomenon. It is important that for healthcare providers to really sit down and assess fear of falling and the fatigue level, and so that you can quantify it and to find out if that intervention coming up would be effective in a way to reduce its risk factors involved. And certainly in our lab here in the Human Performance Lab at Bob Jones University, we're currently studying the relationship between fatigue and balance parameters. So we have a fancy machine in the lab. We hope you get a chance to visit our lab today, but a machine that we can put somebody on a platform here, and we can measure how much they sway left and right or front and back, and in a way to look at how much of the postural sway they're producing with eyes open and eyes closed. And the machine be able to capture this information for us to identify their balance and how is that associated with fatigue. So that's an ongoing study. We hope to be able to understand more about fatigue in relation to balance, which is a risk factor as well for fall risk.
So I'm a speech language pathologist, and inpatient rehab is my vibe. I've worked PRN at a local hospital for about 11 years, along with teaching here, and I love the clinical combined with the teaching. I feel like it makes me more effective. So when I work with older adults, especially older adults that are now in inpatient rehab because they've fallen, cognition is the main thing I'm looking at. So like Valerie, she would stand up at a table and say, confusion is never a normal sign of aging. I would say, what is normal age-related cognitive changes? And that would be some slowness in memory, a little bit longer time and reasoning, and your processing speed of incoming information and pulling it out is a little bit longer, but it's not that I'm consistently forgetting things or consistently having trouble figuring out what is the solution, when up until this point, I have been able to move through life independently, balance my checkbook, go to the grocery store, get everything on my list, those individual activities of daily living. So Stephen and I collaborate a lot on research. And when we looked at fatigue, we see there's a link also between cognition and cognitive fatigue and fall risk. So for those of you who are students, it's almost spring break, but I know that I'm giving a really hard test tomorrow morning. So, and you know, if you're in my class, but as you age, especially those 65 or older, it's interesting that you can have a wiser brain. There's so many more skills that you've developed in life. However, your brain endurance isn't going to last as long before you have cognitive fatigue, or you won't be able to pay attention for quite as much. You need a stretch break. You need a little bit less demanding task. So when they looked at that in comparison to walking, they found that people can't walk quite as quickly. Their gait is a little bit off. It's not quite as consistent. And because it's a little bit off, their balance is off, and therefore they're at greater fall risk. And that doesn't necessarily correlate to their health status and how many comorbid conditions they do or do not have. So programs such as Tai Chi that have already been mentioned that look at balance and gait are helpful to these individuals. So there was a 2017 study that kind of said in the early mild cognitive impairment stage, we can help people still prevent or delay the onset of dementia. In 2020, they came out with more preventative measures. So there's 12 different factors that you can address either in early life, midlife, or late life to help prevent dementia. And they say 40% of the risk factors are preventable. And I know personally the reason why I got into the field is because my mom had a frontotemporal dementia. And so I always want to know, how can I help people age in a more healthy manner, or even prevent what I saw my mother went through, or as we've seen other loved ones go through with Alzheimer's or other dementias. So of course, advanced education, healthy diet, exercise, community engagement. So I know we have senior action centers that we do a lot of partnerships with here in the area that have multi-group music lessons, Tai Chi, balance, red sneakers, and there's other community resources that are so valuable to help preserve cognitive functions and help prevent that dementia. And what they found that's underlying these preventable risk factors is if we adjust these things, so we age in a more healthy manner, our brain tissue is healthier because the rest of our body is healthier. And because we're engaging in activities of daily living, we're going about and able to do things more, use it or lose it, right? Our muscles are stronger, our brains are more active, so we have greater cognitive reserve to be able to keep going. So I'm going to get to the good stuff in just a minute. Not that it's not all good, but mild cognitive impairment is that precursor stage to dementia. And Valerie already mentioned a little bit about it. So you can see in the subcortical area where your memory is, your new learning, some of those different skills, that there's a shrinkage in cortical tissue if the individual has mild cognitive impairment. But what the research studies have recently suggested is if we do a multifocal intervention, we look at nutrition, we look at physical activity, we look at getting people in groups, actively engaging and addressing hypertension, depression, diabetes, any comorbidities that would help them age faster, then what we do is we greatly prevent the rate at which we see those cognitive age-related changes. So one of the first studies to really look at a multimodal intervention was 2 years in length. And they had a large group as a randomized control trial of individuals that got a multimodal intervention that was physical, cognitive, dietary, and also looked at those vascular risk factors for developing dementia. And it was amazing that at the end, this group that had the intervention compared with those who did not receive an intervention, they had 25% higher scores on neuropsychological testing that kind of looks at your broad cognitive ability and the executive function. So that's your attention, thought organization, problem solving, all those things you go about to write your grocery list, get everything off your grocery list, balance your checkbook. The executive functions were 83% higher in those that received the intervention. And processing speed, which we know is affected by aging, was 150% higher in the peers that received the intervention versus the peers that for 2 years did not receive the intervention. So if we intervene, those that are aging, and we stimulate certain things, we can once again, we can address fatigue, we can address balance, but we can address the cognition. So more recently, they've done some specific studies. This one was with that mild cognitive impairment pre-dementia group. And it was 105 older adults. They had 3 groups. They received 8 2-hour sessions. So they received 16 hours of cognitive therapy, basically, if they were in the cognitive group. And what they found was that those who had the cognitive training had improved cognition, well-being, and generalization to those activities of daily living that they do independently in the community at 3 months and at 6 months. They just reported a better quality of life. They reported they were able to do more and had greater overall cognitive functioning, although they would probably use non-speech pathology terms. The psychosocial and no contact conditions did not show the same results. So once again, intervention works even if you have cognitive impairment. And these individuals were in social groups. That was another big component of it, matched with similar cognitive impairment. This was a much larger study, the active study. It looked at 2,802 adults, 65 or older. And we know 65 is one of those benchmarks for when we see a little bit more cognitive disruption, that memory, processing speed, and problem solving. So once again, we don't have a lot of therapy that was offered. It was 10, 60 to 75-minute sessions. So you're looking at about 15 hours of therapy. And this study did the intervention, small groups, they focused on those specific age-related cognitive changes that we know are going to change, the memory, reasoning, and speed of processing. They looked at those participants, didn't give them any more intervention. At 5 years and at 10 years post, they had improvement. At 5 years post, these individuals still show the same benefits of memory training, or maybe even a slight improvement over right after the study was completed. And then at 10 years post, compared with the peer group that didn't receive the intervention, they had greater reasoning ability and processing speed, and those individual activities or daily living were better. So if these individuals were 65 at the start and then they were 75 at the end, they actually performed higher cognitively and more independently at 75 years of age as a result of about 15 hours of cognitive group interaction. And 60 to 70% of them reported they were good or better off than at the start of the study. So based on our fall risk intervention, our investigation of fatigue and how that there's a lot of variables in there. So there's a lot of things we're looking at. But if we do a social cognitive intervention for healthy older adults in our community, we combine it with gait and balance training so we prevent fall risk. And we weed out more of this fatigue associated with cognitive changes and just being able to independently go about daily life. It's going to be very interesting to see what's going to happen. So for those of you managing care in the community, if you can plug your seniors into more resources, that would be great. Or if you're in a facility and you can think about maybe connecting your physical therapist and your speech pathologist and your OT, it would be neat to see how much we can help our seniors in this community thrive. So thank you for your great attention. We have a 15-minute break. Feel free to stretch your legs, get some more coffee, water, and we'll see you in 15 minutes.
Thank you again for being part of the symposium today. And we have some very, very good presentations. We have learned a lot. And we have one final presentation that we would like to make. It's a study that has been done, and we are kind of going in the final conclusions of that study. Very interesting one. We have spoken today about healthy aging. One of the interests of the Center for Community and Global Health is social justice, equity. All the programs that we start at the center, we add for all at the end. So when we say healthy aging, we add healthy aging for all. And we wanted to finish our symposium by zooming in on one specific populational group. And our research, the title of it is what you see here, Equity in Aging, Barriers to and Facilitators of Shelter Use in Aged Individuals Facing Housing Insecurity. So I'm doing this research with my colleague, Dr. Amy Hicks, and I will be presenting the first part of the research, and Dr. Hicks will present the findings. So very interestingly, remember our first presentation of the day, Dr. Moon says something very interesting. In 2030, which means 8 years from now, in South Carolina, our population of seniors will be 1.1 million. In 2034, which means 4 years later, here in this country, at the national level, for the first time in the history of the United States of America. As you can see here, it is projected that older adults will be outnumbering children. So between 8 to 12 years from now, we'll be dealing with a completely new society. And it's coming, and it's coming fast. And back in 2015, there was a conference, actually high-level meeting at the White House called the White House Conference on Aging. And the executive branch came out with a policy brief with some very strategic actions that should be conducted. And those actions are, interestingly, as you can see, the presentations that we have heard today are kind of covering those different areas. And for example, promoting health and preventing disease and injury for prevention, optimizing cognitive health, we just heard it, and behavioral health. And we heard the presentation about community engagement. It's good to do good, feel good, get engaged. We heard maximizing independence. And if I remember very well, that was the last slide that Dr. Moon showed. So there is a movement that has kind of started to meet the need of that new society that is coming, and that is coming so quickly to us. But in that movement, there is a question. Yes, we are preparing for that new society that is coming. Yes, we have those plans and strategies and policies in place, but are they working for all? Are they working for all? And this is where your equity, your social justice lenses come in the equation. Because there are some people who are living on the margin of society. And sometimes general policies fail to see them. And at the center, we have that model for moving forward. And that's kind of, we don't want to forget anybody. We want everybody to be involved. And this is why we are doing intensive research on homelessness, and in particular, aged homelessness. So back in 2018, a big group composed of researchers from this country and from Canada, so a North American research team, they did very, very interesting studies. And the title of those studies were America's Growing 50+ Homeless Population. Here are some findings. 95,000 elders living without stable housing by 2050. That's a big number. We are talking North America, 95,000. The homeless age at a faster pace. They might be 40, they will look 60. So premature aging. So all the symptoms and signs that we have discussed with Dr. Chen, Dr. Benge, with Dr. Peterson, all those signs are happening at a faster pace and at an earlier age. Dr. Benge mentioned 65, but for them it's 45. And not only that, the studies also found that there is of course, a higher rate of mortality, 4 times higher. And there is also 30% of increase in the visit of ER. The study came out with some signs, and what I would like you to think about when you see these slides, okay, those are the impairment, and we saw the cognitive impairment, physical impairment, musculoskeletal impairment, and all the systems. But what I would like you to think when you see these slides is that notion of intersectional vulnerability, which means that, okay, probably you will have an elderly individual having impaired ability to perform basic personal care, or they might have, for example, a 50% risk of falls in the previous year. But when you are talking of the homeless population, all these come together. So it's not just one, it's all of this, minimum 2 or 3. So we did here at the center with our Canadian counterparts, we did a study some years ago about rheumatic disorders that were found in the aged homeless population. And actually there is a very nice poster there. And we found exactly the same thing. We found that joint disorders and the risk of fall, what the other researchers described earlier, we are seeing it in the homeless population. So, I mean, think of all those things that have been described happening in someone who doesn't even have a stable house, who is living under a bridge somewhere. And this is something, when we published this paper, we sat down and said, okay, we are doing something here. And this is how we started our collaboration with the Greenville Homeless Alliance, and that they were part of this research. They are part of this research that is going on. So we asked, here are the questions, and it's very good that we have policymakers, we have frontliners, we have researchers here. Here are the questions that we will have to kind of ask at the high level to do what we call an ecosystemic approach. So for example, at the policy level, the question becomes, are current homeless reduction policies, strategies, and programs adapted to the needs of an aging homeless population? That's a policy question. It comes down to the next level, community-based organizations. And actually, Dr. Mann mentioned something very interesting. And we have research actually that supports this statement that she made earlier, very strong research actually, that faith-based organizations, when they enter in the sphere of public health, it helps. Because they come with that connotation of trust. The people on the ground trust them, and that helps in public health. I mean, we have seen it with the COVID-19 pandemic. So are those community-based organizations, are they equipped to meet the needs of the aged homeless individuals? And then we kind of narrow down the question at our level and to kind of ask, what are the factors that are influencing the use or non-use of the different shelter systems that we have here in Greenville? Why shelters? Actually, we have very good research that shows that the use of shelters actually is kind of a transition toward a more stable housing. So if we want an exit strategy that is going to work, you want an increased uptake in shelter utilization. The goal and objective of that research, of course, as I've stated earlier, the goal was to identify those factors that will influence the use of shelters. And more specifically, we wanted to collect and analyze some data that will describe the experience that the aged homeless have when using the shelters. In terms of method, I mean, the conceptual framework that we use were in general, there is a model that has been there since the 1980s, and I think it was developed by Pekinski, and it was revised in 2000 by Gelber. And that model kind of states basically, people are using social services based on certain conditions. Those conditions should affect availability, accessibility, affordability, adaptability, and acceptability. And they are influenced by some push or pull factors that we call the enablers and the predisposing factors. And these are going to work together to determine the need to use the shelters or not. So it's a very good model. We have used it a lot in the hospital system, and for social services, it will be something worth kind of giving a close look at. So we designed a study, and it was not a study that was designed out of the blue. Actually, there was a similar design that was used in the Eastern Coast, and it will be a qualitative inquiry, and we will conduct basically some semi-structured interviews, and those interviews will include participants from the area, resident, quote, unquote, of South Carolina, facing housing insecurity, and all age 55 years and plus. The study was approved by Bob Jones University Institutional Review Board. And so here are the participants. We had 2 big shelters here in the upstate, and for obvious reasons, allow me not to say the names. And actually, there were 2 shelters, and there was 1 day center in the upstate. So the day center will offer social services to the homeless population, but they will not spend the night there. So that will be excellent to kind of go and see why they are choosing a day center instead of a full shelter where they could spend the night. And we had 52 participants, among which 30 were sheltered and 22 unsheltered. The age span varied from 55 to 75, actually. And the sex ratio was 44 men for 12 women. And ethnicity, 24 African American, 27 European American, and 1 Asian American. And the homeless experience went from 2 weeks for the shortest to 45 years for the longest. And these were the study participants. And at this point, what are the findings? And I will turn it over to Dr. Hicks. So thank you very much.
Okay, I'm Amy Hicks, and I pulled the short straw and got to be the very last speaker of a long day. So I want to thank you so much for sticking with us and being such a great group of participants. I have learned a lot today as we've gone through this. I've really enjoyed it. Just to give a little bit of my background on this study, I really have enjoyed doing this study a lot. Here at the Center for Community and Global Health, I'm the assistant director, and our motto comes directly from Micah 6:8. It's do justice, love mercy, walk humbly. And I see this as an excellent way for us to be in the community doing that. I'm going to pull this down too, for living out those principles, but also getting students involved. So every one of those 55 participants was interviewed by students. So we, as the co-PIs, were not participating in the actual interviews in order to keep us kind of unbiased as to what we would read and what we would see. But the students would come back and just talk about these amazing conversations and what they had learned. And it was an excellent way for them really to be involved. So I'm thankful for that. If nothing else ever happened, that's an excellent outcome. But we did find other outcomes as well. So of those 55 surveys that we did, we categorized them into 2 different categories, which we kind of alluded to. There were sheltered participants, and then there were unsheltered participants. And then for each of those, whether they're sheltered or unsheltered, we looked at what were the barriers to them using shelters, and then what were the facilitators. So we grouped according to that. And then what really kind of shook out of this is that there are 3 categories of barriers and 3 categories of facilitators. And those are psychosocial, environmental, and then institutional factors. So we're going to structure each of these around those 3 types of factors. So for barriers, first of all, and I want to say one of the things that we really learned as we went through this is that that barriers are not always consistent. So what I mean by that is that what's a barrier for one person, we would find was actually a facilitator for another. So I'll show you what I mean by that here in a second. But when we looked at psychosocial factors, one of the things, I think we could probably all relate to this, as people age, there's this desire still for independence and freedom. And so sometimes we saw for certain individuals that shelter use was difficult for them because they did still desire their independence and freedom. They desired respect. And when they perceived that they had an adverse experience in a shelter where they felt unrespected, they were much less likely to go back. Third, this is one that I don't know that we were necessarily expecting, but it became a very constant theme throughout this. Elderly individuals, I hate to say elderly when you're talking about 55 and older, right? Because that's not all that far down the road. But those 50 and higher, so even have 50 and higher, had difficulties with multi-generational living. So they had a hard time living with people who were 20, 18, 24. And sometimes some of those were a feeling of being disrespected or actual incidents that had happened, like I was robbed by younger participants. And so we started to see this theme come out that we would like elder-specific shelters. And we'll talk more about that as we go through. As far as environmental factors, again, shelters that were designed around the needs of elderly people. So if we see, we've gone all day talking about these increased physical and cognitive needs that people have. And if we say these are pronounced 10, 20 years earlier in the homeless, we see that this becomes a real barrier. So if there are broken elevators, if there are, and we had a participant who had to climb the stairs, but they had oxygen, and that was very difficult. They found themselves relying on others to help them get up and down the stairs. If they had no access to a handicap bathroom, that was very difficult. And then if they happened to be late to the shelter, and all of the shelters are arranged in bunk beds, and many would describe this kind of feeling of panic at a bunk bed, waking up afraid and having a difficult time negotiating that. And then additionally, housing conditions such as privacy. So one of the factors that tended to limit access for some participants, but then others said this was no problem at all. They had no issue with this. If there was a long waiting time, if there was a difficulty accessing the shelter. And then where I would say, when I said earlier that what's a barrier for one person is a facilitator for another, some people, rules were a barrier, but then we'll see for others, rules were a facilitator. Okay, so looking at facilitators, those same psychosocial factors, one of the big things was the feeling that when they were in a shelter, there was a good degree of security and protection. They felt much less at risk than they felt when they were sleeping out in the open, sleeping on the streets. Many felt, and when they felt this, they were very, very grateful for the shelters, a good deal of care, attention, social connections that were able to help them get a job, get them on their feet, and that just allowed them to have interactions with other people. Additionally, environmental factors. They valued not only the quality of the service, but the variety of the service. So if they had access to medical care, which they do frequently when they stay at shelters, they have access to New Horizons, among other things. So they have more access to medical care. They have access to social workers. If they have access to a counselor, that's very highly valued. And then handicap accessible. When they found that, that was an important facilitator. And then for institutional factors, those that offered a continuum of care, So as we talk in healthcare a lot, I teach population health management. A few of my students are in here. We talk a lot about how healthcare is moving to this continuum of care, trying to meet people at every stage and incorporate all of these different needs that they have. Well, so much more of this is necessary as we move into a continuum of care for homelessness. So not just shelters, but medical care, mental health care, job training, the many different ways that can allow people to get up, pick themselves back up with help and be able to move out of homelessness and into permanent and stable housing. And then one of the big factors that we more often found that people appreciated was an exposure to the rules, to religion. The rules helped those who were in shelters feel very secure. They felt like it brought a lot of consistency. They knew what to expect. It just kind of, greased the wheels of living together with a lot of other people that you just didn't know. And so that was actually a large benefit to a lot of the people who chose to take advantage of the shelter. Okay, so these results really line up with the few other studies that have been done. Unfortunately, a lot of the research that has been done has looked at younger populations. And so we're seeing this need to look at older populations because that's what's really growing. Even in homelessness, the growth in the aged population is even more pronounced than in the general population. So we need to meet these needs. And so this was a study published in 2017 that looked at patterns of shelter use among older adults as well. And it also showed that whether or not they were willing to think about a shelter was dependent on care, protection, security, and respect. So these psychosocial influences that allowed them to feel comfortable with a shelter. And then enabling factors that allowed them to get into a shelter. So again, availability, acceptability, adaptability. So some things that were part of this are things like privacy. Older adults don't really want to live in a giant dormitory style room. I wouldn't either. You ever have those nightmares about you had to move back into a dorm when you're grown? I've had a few of those, but and students, don't worry, you're good. And but this privacy and independence is very important to many of them, as well as an elderly friendly design. So how do we rethink shelters with handicap accessibility? And some of our shelters here in town, I want to give them a shout out. They're doing a great job with instituting respite care for people who are coming out of the hospital. They don't have a home. They're too medically fragile to just be back on the streets. And so we're seeing this, even one respite care for women was open just within the last couple of weeks. And those are very important. They're an important part of the continuum of care in keeping people out of the hospital again. And then that this would be something that they can get into with a short waiting time. And this lines up with the study in 2014. And this looked in Singapore. So we are all humans. We all have the same needs and desires. So it lines up very similar with that study. And then needs. Again, how do we reimagine improved accessibility, adaptability by integrating this continuum of care and offering multiple services at one? Because it is shown in 2018, when you do have all of these integrated into one service, people get out of homelessness more quickly. They get into the shelter and they get out more stably. So this leads us to some policy considerations. What should we be thinking about for the future? Well, how do we put policies in place to help shelters, first of all, reduce senior waiting time, maybe allow seniors, like as a very minimum, allow seniors to get in earlier so they're not stuck with the top bunks, but they're able to have a little bit more accessibility. And start to look at what needs to be in place. So not much work has actually been done on this yet. What factors need to be in place to a shelter to make it elderly friendly? How do we start to make this a common thing where we have a continuum of care that people have access to? And one of the things that's being proposed is maybe this looks like something that's kind of in between a senior housing system and a shelter system that's semi-private rooms, handicap bathrooms, age limit on who can participate. But of course, when we talk to the shelters, they're like, yes, we love that. That's great. We need more money. And that's what, that's what we all say. We need more money, but there is a way. How do we get there? How do we advocate for the needs of those who are not seen and help to move this needle and move this along? So this is our first study. We're going to continue on with this. This was just done in the upstate. I think this can be scaled much larger. And we are wanting as one of the next steps to look at, do all of these factors weigh equally, or how can we start to quantify which factors are more important, what needs to be put in place? And so this is another area. And we want to continue to be at the forefront of research into aging and homelessness. But again, along with shelters, that means we need more money and lots of students. So we got lots of great manpower that help to do that. So I want to just thank our partners for one. We have had the Greenville area, the upstate area has an incredible group of people that work in such collaboration in order to attack this problem. And they do a great job. And we are very thankful to have such good partners that we can jump in and work with. So I want to thank them. Thank our students as well, who have done a good job and learned so much in doing this, and the school for the support that they've given to us. And I want to thank you all. You have been excellent audience members today, and we're very, very thankful that you've taken your day and come. Hannah.
You have made it to the end. Almost. So thank you, Dr. Kadio and Dr. Hicks, very much for sharing. And we love what we do, and we are so thankful for each of you for coming today. And hopefully you have many things that you could take away and incorporate in your practices. We are very grateful to each of our presenters today for putting different nuances on the aging population and how we can help them hopefully thrive and age in a more healthy manner. We are also very thankful for each of our student volunteers. It took a village to make all of this come together. Our division staff, especially Mrs. Christina Neal and Mrs. Candace Baker, who put in countless hours to facilitate the smooth running. Our community liaison, Mrs. Anne Marie Schell, who made sure we were on track with everything. And our audiovisual guys who are behind the curtain, but have been incredible to make sure everything runs smoothly for our in-person and our online participants. We would like to thank especially our online participants for joining us from all around the world with the time changes and the different dynamics they are contributing to what we were able to discuss today. And finally, I'd like to thank South Carolina DHEC and South Carolina Public Health educators, as well as All About Seniors Resource and Referral Guide, for helping to get out the word about the symposium and for helping to provide CEU credits. So we hope that one of the things you take away is that at the Center for Community and Global Health and through our global and community partners, that we seek to live out Micah 6:8, do justly, love mercy, and walk humbly. For each of you who have attended today, thank you for joining us. May the information you've learned better equip you to serve others. We also hope that you will join us next spring for our 4th annual symposium called Healthy Aging, Community-Based Programs and Resources. Finally, as you are leaving, we ask that you complete the evaluation form so we have feedback to know how better to improve for next year. And if you're getting CEU credits, if you would drop that form off at the very back desk. If you would like to take a tour of our School of Health Professions building, you may meet back at the research posters where Will is at, and he'll help organize you. For our online participants, you can also join in on a tour of the building. It'll take about 15 minutes for us to get set up, but it'll be available on Zoom. Thank you and have a wonderful rest of your day.